It's a great honor for me to be here today, and I'm Dr. Pankaj Talwar, and Dr. PK Shah is the co-chairperson. He'll be just joining me in some time. So I welcome you all to today morning's proceedings. I know we have been hearing about ultrasound from past now nearly 3 days, and it's really been an academic bonanza for all of us. So today morning's session has got 4 speakers. We have Dr. Vivek Kashyap, whom everybody knows, Dr. Mamta Deendayal. She needs no further introduction. We have Dr. Sonal Panchal and Dr. Jaideep Malhotra. All the speakers are here. So without taking much of your time, I know time is very precious and today is Sunday morning. So without much of ado, I would like to invite Dr. Vivek Kashyap, who will be talking to us on Day-2 scan beyond residual cyst. So before I start, I would like to request all the speakers to please stick to their timings. Dr. Kashyap, please.
Good morning, everyone. Now I'm going to be talking about the importance of a baseline scan and how important it is for our workup in an infertile patient and the patients who are needing further investigations. But first, the baseline. Why are we calling a day 2 or a day 3 scan a baseline scan? Baseline is a line, Baseline is a line that is a base for a measurement or for building up. Earlier, this scan was done with few limited purposes, one of them being to rule out a residual cyst before the clinician could decide on the ovarian stimulations. And if there was a residual cyst, then the stimulation cycles are generally abandoned and the diagnosis of polycystic ovaries is also delayed. But first, a residual cyst. A mature follicle that fails to acquiesce becomes a residual cyst. These are generally lesser than 3 centimeters in diameter and are thin-walled, generally anechoic, but may present with bleeding inside, which may then show up as a hemorrhagic cyst. Generally, if these residual cysts are smaller, the clinicians may still decide to go ahead with the ovarian stimulations. Now, the purpose of pre-stimulation. The purpose of the baseline scan is to help the clinicians have a pre-stimulated assessment of the ovaries and the uterus. This scan gives us an accurate study. But then why? The common reasons for referral for a baseline scan may include heaviness, bloating, irregular periods, heavy periods, post-menopausal bleed, hirsutism, weight gain, infertility, and repeated miscarriages, of course, and pre-IVF cycle and pre-ovulation assessment. The importance to assess a lady before the clinicians can think of stimulating, there are many ways by which we can do the assessment. One of them is a baseline hormone, anti-Mullerian hormones, FSH, estradiol in day 2 or day 3, and the baseline scan. And all of these are useful in deciding the correct stimulation protocols, which is one of the single most important factors for success in ART. Now, what do we look at? What are the purpose of a day 2 or a baseline scan? We look at the ovarian size, morphology, antral follicular count, presence of any residual cyst, determine a good responding ovary from a poor responder, triage the ovaries which are likely to go into OH, that is hyperstimulation, and any mass lesion which can then affect the oviogenesis. At this time, then why day 2? Because on day 2, the ovaries are silent. There are no active follicles or corpus luteum. The hormone levels are at the baseline. We are generally doing a TVS scan, which is mandatory for correct assessment, since a transabdominal scan may miss more than half the details that we want. Routine 2D is done. We have to use Doppler now, and we may employ 3D 4Ds and 3D power Dopplers. First, the baseline scan, we look at the ovaries. We will look at the intral follicles, which are counted in the longest diameter of the ovary using a sweep. This is on a routine 2D, where once we insert the TVS probe, we localize the ovary and we rotate the ovary till the time we get the longest section of the ovary. And from one end to the other end, we'll sweep the ovary and count the number of follicles. Then came in some techniques of 3D, where we use the vocal, that is volume calculation by volume. This can be used to calculate volume of any structure by rotating that saved volume. And this is done by drawing a circumference around the ROI till the machine calculates the accurate volume. This is more accurate than if we calculate the volume using 2 images. Now, once we get this volume, we can calculate the number of follicles using inversion modes, which can then pick up even the tiny follicles. And we can use the Sono AVC, which can pick up all the follicles. The advantages of Sono AVC is that it can pick up even very, very tiny follicles which are lying behind in the edges of the ovaries as well. We can get the size of every follicle in all the 3 planes, the average diameter, and we can get the volume of these follicles separately on these machines. This has made a life a little more comfortable. And this machine will also color code each follicle separately so that we can identify each follicle in a different way. Using the same volume that we obtained using vocal, we can calculate the stromal volume and echogenicity by setting a threshold level which differentiates follicles from rest of the ovarian tissue, which means using this technique, we can know that in that ovary, what is cystic areas, they are calculated separately as a volume, and the remaining ovary is the solid ovary, which is calculated as a volume. So we can take the ratios and find out whether there is some stromal excess in these ovaries. Also, we can take a look at the echogenicities of the ovaries, and we are doing spectral Doppler of the ovarian stromal arteries now. The RI values and peak systolic values are important here. But before we go about doing a Doppler, we must remember to set the PRF values at a lower level, say 0.02 to 0.03. The wall filters are also set quite low. Gain settings need to be adjusted, and we need to choose a vessel within the stroma that is the brightest. And we have to avoid the vessels at the periphery of the follicles, because then those are the vessels which are then belong to that follicle and not to the ovarian stroma. So now we can rotate the ovarian volume once we take the part Dopplers so that we can see the vascularity all around, and thus we can even pick up the perifollicular blood flows. So we can obtain the volume of the ovaries using a part Doppler and the stromal vascularity. We can thus have ovarian angiograms also. And what is more important is that we can have a quantification of the vascularity in the ovaries. Like, for example, the vascularity index, which tells us about the abundance of flow in the region of interest. The flow index is a measure of average intensity of the flow, and the VFI, that is the vascularity flow index, is a measure of the perfusion index within the ovarian stroma. So then we'll discuss about this later. But then why bother about all of this when we can simply do the intral follicular count and finish off? But first we must know what is a normal ovary. The normal ovary, the volume should be between 3 to 7 cc. The number of follicles between 5 to 10. The stroma should be isoechoic to that of uterine myometrium. The stromal vessel RI should be between 0.5 to 0.7. Peak systolic possibly ranging between 5 to 9. And flow index between 10 to 15. Now these normal ovaries will respond to standard stimulation protocols once we get all of this data. They can produce adequate, good quality follicles for ART. But then we must identify the ovaries which are low reserve ovaries. There are lesser number of follicles in these ovaries. Generally they are less than 4 to 5. These ovaries are also smaller in size because of the less number of follicles. There's less ovarian reserve. The ovaries tend to be smaller. It is less than 3 cc volume with maximum diameter less than 2 centimeters. These ovaries produce less follicles, but the quality of follicles can be good. We must remember that a low reserve ovary can produce good quality follicle. Now, these kind of ovaries, and then we have to identify the ovary which has got a high vascularity. Now, these ovaries are the ones which are going to require a lower dose of stimulation, because then they tend to go into hyperstimulation. So therefore, we have to be careful about that. And then I'll talk about the poor responding ovaries. These are reduced blood flow in the stroma, may lead to poor response to stimulation. Measurement of ovarian stromal volume in early follicular phase is important so as to determine the ovarian response for ART. Ovarian stroma shows low PSV, that is less than 5 centimeters per second, and high resistance, that is RI more than 7. These ovaries require higher doses of gonadotrophins. Therefore, on an ultrasound, we have to identify these kind of ovaries, and thus we have to convey to the clinicians regarding the dose of the stimulation. Now, then the poor responders, these are the ovaries which are different from the low reserve ones. Poor reserve has less number of follicles, but those which get stimulated, they are quite normal. Poor responders are those which are less sensitive to the stimulation. So the ovaries can be low reserve, but good responding ovaries, or normal reserve, but they can be poor responding ovaries. Now then, to diagnose a polycystic ovary, we need to go back to Rotterdam's criteria, which were that the ovarian volume of more than 10 cc, the number of follicles more than 12, the size of the follicles between 2 to 9 millimeters, the ovarian morphology more important than the ovarian volume now, and there is stromal abundance with increased echogenicity in the polycystic ovaries. Ratio of stroma to that of ovarian volume is also important. S upon ratio more than 0.34 is considered diagnostic of PCOD, and hyperandrogenic PCO have higher ratios. Now the parameters also of a polycystic ovary, the uterine artery PI of more than 3 in polycystic ovaries can be seen, and this is associated with suboptimal endometrial blood flows. The increased level of androgens are thought to cause uterine artery vasoconstriction. This leads to blastocyst implantation failures, and the patients may give you the history of repeated abortions in the past. And then we need to look at the adnexal masses. There could be endometriomas, there could be adenomyosis, which are notorious to interfere in the fertility process. And then we go on to the tubal factors. The real goal for the fertility specialist is that we need to detect the tubal pathology, we need to assess the tubal patency. Of course, we are not covering it in this lecture, maybe later. And we need to fast track the patients for laparoscopy, and we need to fast track some patients for IVF straight away, and we need to increase the diagnostic confidence in the initiation of anti-tubercular treatment in some. Normal fallopian tubes, we must remember, are not routinely evident on ultrasound. Assessment of the tubes improves take-home baby rates in ART. The tubes will originate at the ostia and run through the cornu. They run along the superior margins of the broad ligaments. They terminate over the ovary, usually engulfing the lateral aspect, often inferiorly. So we can see the tubes only when they contain fluid, or when they are thickened, or when they are surrounded by fluid, or when the fluid is injected into them. Otherwise, a normal tube will not be seen. We must remember to identify hydro, pio, or hematosalpinx, which is the features of such a lesion or such a pathology would be that we would be able to see and localize some tubular sausage-shaped structures which are cystic. There could be presence of incomplete septa. The mucosal folds will seem to protrude into the lumen but not reaching the other end. So that is like cogwheeling and beads on string appearance. Another extremely important diagnostic issue is the presence of lady's waist sign, which is that this tube appears to be like a lady's waist. This is some partial constriction of the tube here. So this is one of the cases there it was diagnosed as a tubular shaped cystic structure. And then the use of 3D technology to pick up hydrosalpinx and distinguish it from a cystic lesion that could be a large follicle or a residual cyst. So we can see that if there's some beaking, we can use these kind of technologies to pick up any beakings or to pick up any suggestion of a tubular structure which may be different from a follicle. And then, even on Day-2 scan, suppose we are picking it up accidentally, incidental findings of a dilated tube, and it turns out to be maybe pyosalpinx, we can calculate the exact amount of fluid inside that dilated tube using some of these 3D technologies. This is important because then it is a non-invasive procedure in which we can calculate the exact amount of pus in the dilated tube, and the clinician might want to put up the patient on maybe anti-tuberculous or antibiotics, and after a course, the patient may come back again and we may calculate the amount of fluid. So if the fluid is getting reduced, then we know that the progress of the patient such. So, and this is a huge variety of the tubal pathologies, which could be post-inflammatory, there could be pyosalpinx, tuberculosis, of course, and tubo-ovarian masses. Then we go into the myometrium. After the ovaries, the tubes, and then the myometriums, we know that the most notorious is the adenomyosis. This is a presence of endometrial glands and stroma within the myometrium. Usually this is extensive posteriorly, maybe diffuse, maybe nodular, and diffuse uterine enlargement with normal endomyo appearance could be seen in homogeneous, hypoechoic to heterogeneous areas in the myometrium, and there could be some cystic areas, there could be some echogenic striations, there could be localized inhomogeneous circumscribed areas with indistinct margins. So there's a huge variety how to diagnose adenomyosis. These are some of them, and we must be aware of the pattern recognition, how to diagnose an adenomyosis. Of course, the subendometrial cysts, which may be present at the junction up to 2 to 3 millimeters below the junctions, and they may affect the pregnancy rates, they may affect the decidolization and abnormal concentration of intrauterine free radicals. Now the categorization of this could be that category could be the mild one, which is only microscopic foci. There could be category 2, which could be a focal lesion, and the third category could be a diffuse one with the extension to outer 2/3 of the myometrium or gross involvement of the uterus. The importance, once we come to look at the myometrium, we need to look for the fibroids. And of course, we know that large submucoid fibroids are the ones which are going to affect the pregnancy rate. So we need to identify them. We need to check the vascularity around the fibroid, because it is said in studies that the fibroid which is more vascular are the ones that are likely to grow in future. So therefore, we need to not only measure the size of the fibroids, we need to measure the number of fibroids, we need to measure how much it's indenting or distorting the endometrial cavity, and how much it's going to affect the transport of the sperms and the ova because of these large fibroids. So these are the ones that we are needing to identify. Once they are distorting, we need to tell the clinicians that we need to get rid of these fibroids first. Then the endometrium. Now we need to check the endometrial thickness, which we routinely do, though it's done all over. The endometrial thickness is generally around 7 minimum. Of course, the jury is still there, and some studies say that even less than 7, there could be some pregnancy rates. But then generally we feel that more than 7, we are more comfortable. But there's the endometrial volume that we need to calculate using 3D technologies like the same, we can use this vocal technology. And in that case, we know that the endometrial volume less than 2 ml is 15% success rate. More than 2 is 35% success rate. This is according to one of the studies done in the year 2005. And if it is less than 1 ml endometrial volume, there is no success. Apart from the volume and the thickness, we must look at the endometrial peristalsis, and we then know that this endometrium is now right to transport the sperms and the ova. Then we need to check out the endometrial vascularity. We can take a power Doppler, we can do the vocal, and the machine will tell us what is the vascularity of the endometrium in these cases. So the embryo transfer day, that is not on day 2, but we can take a rough idea and then triage the patients of endometrial flow index. We know that the flow index on the embryo transfer day, but that is not part of day 2, so I'll skip this. And then we need to identify the Asherman's disease. Even on day 2, there could be an incidental finding of Asherman's in that patient. So we need to identify the advantages that the menstrual flow may be liquid inside the uterine endocavity, which may then help us in identifying some small bands, because that is the menstrual flow which may act as a little amount of saline that we may be asked to put into the uterine endocavity. So,
2 minutes are left.
Right, thank you, sir. So then we need to identify the endometrial polyps, we need to identify the endometrial submucoid, because we need to identify a polyp from a fibroid. And then the ways to identify that is that if the endometrial lining is all around that lesion, it's likely to be a polyp, and if the endometrial lining is not all around that lesion, it's likely to be a submucoid fibroid which is indenting into the cavity. Of course, we can put on the color, and generally polyps have got a vascular stalk which is feeding that polyp. Then we move on to the cervix, which is of course tricky to visualize properly. It is important to see if the cervix is bulky or edematous. Nabothian follicles are common and may be associated with healing, which may indicate a chronic cervicitis, and therefore we may also look at such patients who have cervical polyps, which may cause bleeding, and approximately 8% of leiomyomas, we must remember, they occur in the cervix, and we may identify them with a vascular stalk. These are the cervical polyp, and then we can use the cervical a power Doppler in the cervix. Like in this case, there's a mass lesion, and once we use the power Doppler, we know that the vascularity is increased. Also, examining the cervix as a result of cone biopsy of that patient, atrophy of the cervix, radiations, the history of radiations given to that patient, or the history of malignancy is important to assess the cervix. And this is usually detected clinically, but there may be a presence of mass which may be confused with a fibroid. And then we move on to the Mullerian anomalies. Incidentally, and we have done that in our clinics many times, incidentally that patient has had many years of treatment, but the incidental finding of a Mullerian anomaly.
Dr. Vivek, your time is up, please.
Right. So this occurs in 3 to 4%. So I'll just rush through these slides. This is one of the cases of a septate uterus, and this is a case of, we must, in cases of septate uterus, measure the length of the residual cavity. We must measure the length of the septa, the vascularity of the septa, so that we can tell the patients, to the clinicians, if they need any surgery or any procedure. We must identify the bicondyloid uterus from the septate ones, and uterus didelphys. Of course, this is one of my patients who's got absolutely normal marital history, and she's got 2 wonderful children, and she's had no problems as far as her fertility was concerned. Then we must identify the unicornuate uterus. Sometimes there's a non-communicating horn which may press on the remaining endometrium and suppress the endometrial, the peristalsis, and thus cause infertility. Then we must identify the T-shaped uterus, and that may also affect the fertility. So the take-home message is that it is the most comprehensive scan, it is the most important one, and it lays down the path of treatment for infertility. Thank you for your patience.
Good morning, my dear friends. Surgery in the past meant that we were dealing with laparotomies, where We operated first and then saw next. Then came the era of laparoscopic surgery, and this is the case scenario of 1989. This was a 25-year-old girl with primary infertility, was subjected on the basis of an ultrasound finding of intramural 4-centimeter myoma to a laparoscopic surgery. We made the incision. These are true cases and true experience. We made an incision on the uterus, and there was no plane of cleavage, a lot of bleeding. We converted this to a laparotomy to control the bleeding. She continued to be infertile. We then performed a laparoscopy to see what was going on, and it was a frozen pelvis. Of course, we did IVF after that, and she did get pregnant. But the question I asked myself was it worth it? And the answer, my first lesson to ultrasound. To do it yourself, you must learn it first. And so today I stand as a gynecologist in the world of radiology. Yesterday, our approach was that we image by ultrasound, CT, or MRI. We then plan mentally and draw out our diagrams and examination, then a realization whether we should go for conventional laparotomy or whether we should go for minimally invasive laparoscopic surgery. Now we have 3D applications where we have a 2D data set. We could reconstruct the mass that we see. We use vascularity. And then of course we use the glass body imaging, and there are no more surprises. So today, when Dr. Khorana gave me this talk on the clinical dilemmas, I added ultrasound solutions in infertility. I will talk to you today on personal experience of what we do and how we plan strategies based on ultrasound and the changes we made over time. As a gynecologist performing ultrasound, we think like sonologists. We have to understand what is it that the clinician wants, what is it that the laparoscopic surgeon wants, what is it that the hysteroscopic surgeon wants, and what is it that the interventional radiologist wants. But we think like surgeons, because we have to realize that what a surgeon needs is the details, the vascularity, because he cannot touch the object before he really operates on it. He also needs to know the grading, because this is necessary for his planning of surgery. So the methodology of this presentation is, I would talk about the clinical case. I would then go to the ultrasound findings. What are the management strategies and what the evidence tells us? And of course, the take-home messages. I would be today presenting 5 cases and 2 clinical situations. The protocol is we do a transabdominal ultrasound first, followed by a transvaginal, making the impossible things possible. We follow a specific protocol while we are doing an ultrasound of the transvaginal ultrasound. As we are entering into the vaginal cavity, we look at the walls, we look at the uterovesical fold of peritoneum, we look at the uterus both in longitudinal and transverse planes. We then follow the uterotubal ligaments and go and visualize the ovaries on both sides and study them. We follow this strict protocol using dynamic and interactive procedures all the time. Today's case discussion involves 4 main cases: ovarian masses, uterine pathology, tubal pathology, and evidence of tuberculosis that we see on ultrasound. The first case, She is a 28-year-old woman who had presented to the Institute for an IVF cycle for male factor, and we noticed that she had an ovarian cyst that was about 4 centimeters in diameter, and this was repeatedly aspirated in another center before she was referred to us. The ultrasound findings on day 2 baseline indicated that the uterus was normal in ecotexture. The ovary on the right side had an antral follicle count of 6. The volume was 4.5. Then we also found a cyst, and this cyst was a unilocular, well circumscribed 6.5 centimeter cyst with peripherally placed follicles and anechoic smooth inner and outer surfaces, no papillae, no cysts, no septa, and the score was 1. We then applied the IOTA simple rules, which is a very important part of assessment, and what we found that it was a unilocular cyst with no blood flow. It had no M rules, and we know that when you have 2 B rules and no M rules, it's a benign tumor according to the IOTA guidelines. We then, what is it that we did? Because she was recurrently filling up the cyst and it was about 6.5 centimeters, what we did was we did a laparoscopy for her. We opened up the cyst and removed the cyst in toto, and you can see the correlation between the ultrasound pictures and the cyst we removed. It's awesome. And what we sent for the histopathology revealed that we were dealing with a simple cystadenoma. So the next question is, what does the evidence say? The Green Top guidelines guides that if there is a cyst more than 5 centimeters, which is persistent and not disappearing in 3 months, then you need to further evaluate it every month. And removal of the cysts by aspiration actually has an 84% chance of recurrence. Having done this, we go to case 2. This was a young woman who was 38 years old, married 15 years, failed 3 ICSI cycles in another center, diagnosed as a poor responder before she was referred to us for an oocyte donation program. In 95, her laparoscopy was normal. We went ahead and we saw her ultrasound findings. Her uterus looked apparently normal. The right ovary had an antral follicle count of 1, and she was a poor responder. In the left ovary, we found a unilocular cyst with papillary outgrowths, 400 millimeters in size, was the size of the ovary. We then went to characterize the cyst. It was a unilocular cyst with papillary excrescences, maximum height of 7 millimeters. It had irregular walls, but the papillae had not infiltrated the wall, and the vascularity score inside the papillae was 7, and the score was 2 within the papillae, and there was no ascites. We then went into the IOTA EDNEX guidelines, filled up the basal patient data, and then went into the analysis, the column analysis, and we knew from this analysis that she has a risk of borderline malignancy of 21%, a risk of malignancy of 46%, and the chance of it being benign as 54%. Having done this, we did a laparoscopy for her. We did an ovariotomy because it was predicted as a borderline tumor, and she was already coming in for an egg donation program. And when we removed the mass, you can see the comparison to the ultrasound findings. It's really awesome to do a good ultrasound. And the histopathology showed a papillary serous cyst adenoma with a borderline tumor. Going on to the next case, this was a young woman, 26, working in the MNC with night shifts, diagnosed to be a case of polycystic ovaries on oral contraceptive pills, and she had all the phenotype of polycystic ovaries of the severe variety. Her sister and mother were also known polycystic ovaries. She had no history of breast or colonic malignancy in the family. Her clinical examination was a typical BMI of 24, hirsutism score, the Galloway score of 14, and acanthosis and acne, and she only carried a report saying mass in the right ovary. This was a patient seen by me just a week before I came for this meeting. So as a part of the characterization, what we did was we did a transrectal scan because she was unmarried and not sexually active. We described it as a single, well-circumscribed intra-ovarian solid mass in the left ovary, the right ovary being normal, and the dimensions were 46 into 53 with a volume of 65 cubic millimeters. It had well-defined smooth borders and it was a solid cyst. We then went ahead with the qualitative analysis, and what did we see? A color flow was present, chaotic vascularity, and both central and peripheral pattern 3. We did a semi-quantitative analysis with this beautiful E10 that we have just got recently, and the color score was 4. We then went to a quantitative parameter and found an RI of 0.45 and a PSV of 22. We did a breast scan as well, which was normal. We then went into the EDNEX model, and what did we see? We entered the patient data, and we did the column and the radar analysis, which told us she had a 20% risk of malignancy, 79% because of her age was possibly normal. We advised a CA125, a HE4, and an alpha-fetoprotein, and referred her to the oncologist for further treatment. Since it's only a week old, I don't know the results. So let's look at what the differential diagnosis tells us. If it was benign, 79% of the time, it could be a fibroma, thecoma, benign Brenner, Sertoli, or a sclerosing tumor. If it is malignant, we are dealing with either a dysgerminoma, an immature teratoma, a clear cell carcinoma, and if it was metastatic, it could be an adenocarcinoma or an intraductal breast tumor, which we excluded already. So let's look at what is the approach to ovarian lesions. When you are evaluating the ovary, you can either see a normal ovary, a functional cyst, a benign tumor, a borderline tumor, an invasive tumor, or a metastatic tumor. We then have to see whether she's pre or postmenopausal, because if she's postmenopausal, she has a higher chance of having a malignancy, and a younger woman is more functional. So we have to do imaging, and that's why we need it. The next question is, what is the protocol that we follow? We go by the simple IOTA terminology, which is mandatory because we need to speak the same language. We then go to characterize it as per the simple rules, and then we use mathematical models, and we use the mathematical model whenever we have the M2 score, because we use the EDNEX model, which is available as an app on the iPad. So how do we do ovarian lesions now? We do the IOTA guidelines, the simple rules, 75% of the lesions are identified. We then find out whether it's benign or malignant or inconclusive, and if it is inconclusive, we use the predictive models, that is the logistic regression model 2, and if we then know whether it is benign or malignant. If it is unconclusive, then we go for the IOTA index, and we actually get what type of tumor we are using, and this is which we use all the time. Why should we do this? Because we have to find out whether it's benign, because then the treatment obviously is going to be a very baseline wait and see or a laparoscopy. If it is borderline, then we do an adnexectomy. If it is stage 1, then we go in for a laparotomy and staging with lymphadenectomy. Higher stage malignancies, we go for debulking and start chemotherapy. And if it is a metastatic tumor, then of course you have to search for the primary and deal with it accordingly. Now, the case 4. This was a patient who was 26 years old, failed 3 ICSI cycles in another center, had repeated aspiration, and she came in known case of Cox, was treated in the past with repeated aspiration of the cyst. We went ahead, it was an irregular cystic anechoic mass with incomplete septa, restricted mobility, low vascularity, suggestive that we were dealing with a hydrosalpinx. So we started to characterize it, and of course, like the previous speaker spoke, all men seem to be obsessed with women, so they call it the woman's waist sign. I don't know whether it's W-A-I-S-T or W-A-S-T, because it doesn't make one difference when you have a sono AVC. We then reconstructed these images, and they're so beautiful because you can tell the patient before time that she's got a bad tube, she's got synechiae within the tube, and we went ahead and that's what we saw, and we did a salpingectomy. But what should you do in the normal circumstance when you do it? If you find a hydrosalpinx before an IVF cycle, what you really need to do is plan a salpingectomy if it cannot be salvaged. And if it is it can be reconstructed, you should save the tube first. If during the course of IVF stimulation you see it, you aspirate the cyst and go ahead with the IVF, freeze all the embryos, or and transfer them in a natural cycle. The case 5 is a very interesting case, and this is a true case. 36 years old, married life 12 years, and this is a case who had a laparotomy, myomectomy 6 years ago. She failed 2 ICSI cycles, and she reported for an egg donation cycle with us. When we saw her endometrial biopsy, it showed a disorder of phase in the endometrium. We saw a well-circumscribed mass, 8.3 in its maximum diameter. It was intramural, anterior wall and fundal, abutting the junctional zone, peripheral vascularity, as you can see. Both ovaries were not clearly visualized because of the mass. We went ahead with reconstructing it with fancy pictures, but when we do these fancy pictures and see it exactly the same on a laparotomy, it really feels very good. We then went in for a laparotomy because it was a 7-centimeter tumor, and a previous myomectomy we anticipated adhesions. So in the laparotomy, what we saw was a well-delineated tumor, and we sutured it in 2 layers, and we were very happy with what we did, till we cut the tumor after the surgery was over and found solid and cystic areas. The report, to our surprise and shock, came as a sarcoma. We know that we see 1 in 120,000 sarcomas. You can see a sarcoma cannot be diagnosed very clearly on ultrasound, particularly if it is not very vascular. So what is the moral of the story? The moral of the story is never take life, your husband, and a woman's myoma for granted. There are 2 clinical scenarios that we're going to talk about, and this is, I've seen a submucous myoma. What do I tell the hysteroscopic surgeon? You need to first confirm that you're dealing with a myoma, or you're excluding it from a polyp. You need to perform an SIS, that is a saline infusion sonography, and study the submucous myoma in the luteal phase, because then it can delineate very well and you can see the junctional zone as well. You then need to characterize the fibroid according to guidelines, and you need to plan out the strategies of management. Having done this, you confirm that you are dealing with a submucous myoma. By the peripheral vascularity, confirm it on ultrasound, or you see the pedicle sign and call it a polyp. Having done this, we always do an SIS, a saline infusion sonography, and we delineate the fibroid, the position, the size, and its penetration into the cavity. Having done this, we plan hysteroscopic surgery based on either the Van-Steker guidelines as in the past, or we use the Lasmar score, which we do now. So let me tell you about the Lasmar score. The scores are 0 to 4, 5 to 6, 7 to 9, and this tells us whether we should do a hysteroscopy or hysteroscopy 2-step or a laparotomy to remove the myoma. And this Lasmar score is based on size, topography, extension to the base, penetration, and lateral wall extension. I know I have 4 minutes, my dear chairpersons, and I'll complete it. So we look at the size based on 0, 1, and 2 scores, and we then look at the topography, whether it's in the upper, middle, or the lower zones. We then look at the extension of the base, how much the myoma has actually come into the base, and that's why we perform the saline infusion sonography, because this is extremely essential. There's something called the The penetration into the myoma, this becomes very important because the myometrial free margin, as I learned it when I studied it, was about 3 millimeters, and anything less than 3 millimeters means you can perforate, till I saw this wonderful paper which said that the uterus is a contractile organ, and when you are actually removing the fibroid, the uterus contracts over it. And as you can see this study here, you can see that when you start it was 3.9 millimeters as the score of the myometrial free margin, but as you removed the myoma and you were monitoring it on ultrasound, it went up to about 13 millimeters. So now we are pretty confident doing this, and sometimes we do it on ultrasound hysteroscopic resection as well. If it is a lateral tumor, we have to give it a score of 1 because these are difficult tumors. The number of tumors is extremely important because if you find more than 3 masses that are into the cavity, please send it to your neighbor because that's the best thing to do. They are very difficult to perform, so send it to your nearest rebel, competitive gynecologist. When is it easily done? When it is a small fibroid with a higher protrusion ratio, smaller intramural extension, and parity. If, however, the protrusion ratio is smaller and the larger fibroid with intramural extension, these are the more difficult ones to handle. The last one is a clinical situation. In our country, we know that, at least in our center, 30% of the patients are having tuberculosis of some kind. So all these pictures are real pictures. We will discuss what are the possibilities of seeing ultrasound diagnosis of tuberculosis. So the echogenic inner rim that you can see, the presence of fluid in the endometrium, the interrupted endometrial echo that you can see very clearly shown here, and that's the hysteroscopic correlation. You can see echogenic foci in the uterine cavity. You can see this on the reconstructed view towards the junctional zone. You can see it on hysteroscopy as well. And these are some pictures with their correlations. Echogenic foci can also be seen within the cervical canal, and these are pictures as well. Total distortion of the junctional zone is pretty common in these patients, and these are the patients we advise surrogacy based on ultrasound. A T-shaped uterus is not a congenital anomaly like the DES exposure ones. We see it in tuberculosis as well, and these are some of the correlative pictures. A myometrial cyst is seen, but when you put the vascularity, it is poor, and that's how you differentiate it from adenomyosis, and this is how it looks on laparoscopy. Serosal adhesions can also be seen. You can see both laparoscopic and ultrasound pictures. Tubal involvement, here you can see caseated material within a thickened tube and absence of the fimbria very clearly because there was ascites as well. And that is a reconstructed view. And sometimes these pictures of hydrosalpinx are so beautiful that I want to put them up in my drawing room. You can also see a hydrosalpinx, and you can reconstruct it by the inversion mode as well. The interstitial portion of the tube can also be documented by the vertical orientation of the tube, and that's how it looked on laparoscopy. So I've just given the correlations because I want you to realize that ultrasound is one of the diagnostic tools that actually guides us. I'm on the last 3 slides. I know you are in the Army, so I know you believe in time, but 1 minute more because I'm a gynecologist. Ovarian echogenic foci, both around the follicle, and vascularity, and of course, you can see the deposits of tuberculosis as well. Tubo-ovarian masses, you can see them all the time in these patients with tuberculosis. Adnexal fixity, the flap sign, and of course the reconstruction, you can see exactly what you see. And you know who gets impressed the most? The patients. The peritoneal inclusion cysts are seen as well in these patients. Ascites, these are pictures that Dr. Praveen lent me, the last few pictures, particularly this one is what Dr. Praveen gave it to us, and he's a part of our group. So these are the laparoscopic correlations as well. So what have I learned? I have learned the eyes do not see what the mind does not know, But with the advent of ultrasound, the eyes see and are able to see what the mind is now prepared to comprehend. This presentation would not have been possible without my colleagues at work who actually, along with Dr. Prashant Mangeshkar, who's our laparoscopic surgeon, taught me ultrasound and helped me compile this data that you see today. All the pictures are real pictures from practicing over the last 35 years. I thank GE for the wonderful machine E10, Mr. Ganesh, who heads it, and the application specialist, Gitanjali, who taught me a lot along with Zenith. And the application specialist and Team G, I'm not advertising for them, I'm just grateful to them. Most of this work would not have been possible but for my patients who teach me every day new lessons in ultrasound. And all of my colleagues sitting here in this meeting who teach me the need to make beautiful pictures. Thank you very much for your patient listening.
My first talk is on endometrial receptivity, and implantation has been the weakest link in the success of infertility treatment and is highly dependent on the endometrial quality. And the quality of the endometrium, we know, is affected by two things. I mean, it's judged by two things. One, whether there are any pathologies or not which are affecting in the sense they're invading or distorting the endometrium, or what is the response of the hormones, or response of the endometrium on the hormones. And in this talk, we are just going to talk about the response of the endometrium to hormones, because the next talk is going to cover the rest of the things. The endometrium, we know, is a receptor organ for the majority of the hormones involved in fertility, and therefore the study of its morphology and vascularity is thought to explain the mysteries of implantation failure. And the best time to evaluate this endometrium is the pre-ovulatory or the peri-ovulatory phase, we all know, because that's the time when it's a multi-layered endometrium, and any endometrial pathologies would be best seen. Even the subendometrial pathologies, because it's the thickest, would cause the greatest impact. But still, I insist that the study of the endometrium for its receptivity must start at the baseline. A lot of it has been already discussed by Dr. Vivek, but I want to specify that you must not see any blood flow in the endometrium on the Day-2 scan, in the subendometer or in the endometrium. And these have been proved in the studies done just on color Doppler and also on a 3D power Doppler. The study on 3D power Doppler says that if there is any subendometrial vascularization, the pregnancy rates are lower. On the baseline scan, if it is there, the pregnancy rates are lower in those patients. This is so because when we do a baseline scan, we know that the estrogen and progesterone are at their lowest levels. And it is these two steroids which are responsible for the vascularity of the endometrium in the follicular and in the secretory phase respectively. So if these hormones are both at baseline, that means there should not be flow. If it is there, it is pathological. And what can that pathology be? Most likely it would be an endometritis, which would definitely affect the endometrial implantation potential. Moreover, the intact regular endomyojunction is an important sign of a healthy endometrium. And the junctional zone is also the thickest on the baseline scan when the endometrium is the thinnest. So that is also why we must always do a baseline scan and check the endometrium for assessment of its receptivity. An irregular or an interrupted endometrium, or even if there is a differential thickness of the endometrium, it is a strong indicator of either adenomyosis or endometritis, and therefore a poor endometrial receptivity. Of course, we know the endomyojunction is also affected in malignancy, but we would not discuss that now. Coming to the pre-ovulatory phase, of course, the thickness minimum 6 mm, preferably 8 to 10 mm, as has been already mentioned in the morning. Morphology is important, not only the thickness, and it must not only be triple line or a multilayered or a trilaminar endometrium, but it should be grade A or B morphological pattern. And what do I mean by that? We are just going to that in a while. Before that, let us finish up with the thickness. Even when the pregnancy occurs with the endometrial thickness of 6 to 8 mm on the day of HCG, the rates of preclinical miscarriage and clinical miscarriage were about 22% and 15.6% respectively, as compared to only 0% and 13% respectively when the endometrial thickness was more than 8 mm. Therefore, I insisted preferably 8 to 10 mm. Apart from the thickness, the dynamicity is an important sign. An endometrium may be 7 mm from, say, mid-proliferative phase, and it remains so. It doesn't grow as a bad endometrial receptivity. So like the follicle, the endometrium also has to grow. Of course, the speed is pretty less, but it has to grow, and only then it is a good endometrial receptivity. It is because it is correlated with the rise in the estradiol levels, which is a result of the growing follicle. The endometrium behaves a little different in the natural and the stimulated cycles. What happens in the natural cycle? It increases in thickness 1 to 2 millimeters daily. In the proliferative phase, endometrium starts becoming multilayered as 6 days before the LH surge and remains triple line till 7 days after the LH surge. This is so because we know when the secretory phase sets on, it is first the outer margin which starts becoming fluffy, and gradually the echogenicity proceeds from the periphery to the central line. So till 7 days after ovulation, it still is a multilayered endometrium. It decreases by 0.5 millimeter on the day of LH surge, and that is because of the initial progesterone exposure, which would lead to the compactness of the endometrium, and it further increases 2 millimeters during the luteal phase. Whereas in the stimulated cycle, especially if it is a CC cycle, its behavior it's a little more different, and the endometrial thickness increases at a faster rate in the CC cycles than in the spontaneous cycles in the late proliferative phase. And this is due to the release of the anti-estrogen effect and increased estrogen due to multifollicular development. So initially, when you see the follicle is growing, the endometrium is not growing, and you have more than the spontaneous cycle. Along with the increase in the endometrial thickness, Stromer et al. Have also noticed a mild increase in the length of the endometrial cavity, though it is not noticeable by most of us. Endometrial peristalsis also can be seen, and the normal rate of a normal number of peristalsis should be 3 to 4 in a minute for a good receptivity. If it's low, that means it's a very restful endometrium. It's not going to allow the sperm transfer. If it is too much, it's not going to allow implantation. But it is important to notice that in this stage, the endometrial peristalsis is from the cervix towards the fundus, as you can see there. The endometrial morphology, I told you that we need a grade A or B endometrium, and this classification is Smith et al.'s classification, and it grades the best embryo as grade A, B, and the C is the worst. And the grade A endometrium is when it is a multilayered endometrium with the intervening area which is as echoic as the anterior myometrium. And this is because the secretion in the endometrial glands, and also because of the vascularity, the blood vessels which have started penetrating inside the endometrium. When it is grade B, it is a multilayered endometrium with intervening area which is hypoechoic to the myometrium, but this is also good for implantation. And grade C is a homogeneous isoechoic endometrium. Remember, this is very different from the secretory endometrium, which is a hyperechoic endometrium. This is isoechoic to the myometrium. And this was thought initially to be the worst for implantation. But the later studies have shown that the vascularity has more impact, and we will go to that in a while. A little bit of fluid in the endometrial cavity just pre-ovulatory can be considered normal. It is just a sleet-like fluid, and it usually stays for less than 24 hours. Coming to the vascularity studies, nearly the same time as the follicular vascularity, the spiral arteries start extending towards the endometrium. The endometrial and the subendometrial flow increases in the follicular phase and reaches its maximum 3 days prior to ovulation. Increased estradiol levels during the proliferative phase have an angiogenic effect on the junctional zone vasculature, which provides the nutrition and the hormonal stimulation necessary for the endometrial development. And the segmental uterine perfusion demonstrates significant correlation with the hormonal and histological markers of uterine receptivity, reaching the highest sensitivity for the subendometrial flow. So these are all the reasons why we think that the endometrial and the subendometrial vascularization is probably the best prognostic marker for the ongoing pregnancy. There are studies which have shown that if the endometrial and the subendometrial flow is absent, there is a high chance of the failure of implantation in the IVF as well as in the IUI cycles. In the absence of endometrial and the subendometrial flow on the day of embryo transfer, more than half of the pregnancies will finish as a spontaneous miscarriage. That means even if you are glad there was no flow, and the implantation has occurred, you must be very watchful for the abortion. It is very much likely. If it is so important, we need to make it a little more objective than subjective, and that is why the endometrial vascularity has been divided into 4 zones. If the blood vessels are reaching only the endomyojunction, it is zone 1. If they are touching the outer hyperechoic line, it is zone 2. If they are coming to the intervening area, it is zone 3. And if they are touching the central line, it is zone 4. This is the classification by Applebaum, and Zaidi et al. Have also given another classification in which the zone 1 is type O, zone 2 is type 1, zone 3 is type 2, and zone 4 is type 3. So you can follow any one terminology that you wish to. This vascularity must cover at least 5 millimeter square area of the endometrium. That means if I am saying that the vascularity is reaching zone 3, at least 5 millimeter square area of zone 3 must be vascularized, because that much area is required for the implantation to occur. If it doesn't, that means the vascularity is inadequate. It is easy to measure a 5 millimeter square area because you can draw a square in the zone 3, but if it is reaching zone 4 or only zone 2, which appears linear on your B mode, it is not possible to measure the 5 millimeter square area, and therefore an easier way of doing it is if at least 5 vessels from both the sides close to close are reaching a particular zone, that means that zone is vascularized. If they are less than that, that means it is not enough for the implantation to occur, and this has been proved in the studies. Now, why is this important? We know that if it is not reaching the inner layers, it may result into implantation failure or abortions. And to prove this, there are several studies. If you open the net, you will get at least 50 to 100 papers on the same topic. I have quoted only 2 here, and you can clearly see that the implantation rates, the pregnancy rates are almost double when the vascularity was present in zone 3 and 4 as compared to when it was present only in zone 1 and 2. And this is our own study, which also shows that when the vascularity was present in zone 3 and 4, not only the biochemical pregnancy, the actual pregnancy on ultrasound also rate is much higher, and the abortion rate you can see is pretty low. Significantly low, and therefore you must wait for the vascularity to develop till zone 3 or 4. It might not develop in some cases, and the first and the most important cause is inadequate follicular maturity. So don't go by the size of the follicle. You have to assess the follicular maturity by Dopplers, and that we will see in the next presentation. Less estrogen receptors in the endometrium, in which cases you might have to give them some capillary enhancing agents. It may be because of local disease in the endometrium, inflammation or Eschermann's or endometriosis, which has an immunological cause also to not allow the endometrium to develop, the vascularity to develop, and of course hyperprolactinemia. These vessels must have an RI of less than 0.6, and Endometrial neoangiogenesis, again, like the thickness, is different in the natural and the stimulated cycles. It is 35% less in the stimulated cycle, but still, in spite of that, it has to reach zone 3 or 4. I do not, or we do not believe in the subendometrial flows because we know the implantation is going to occur inside the endometrium and not outside the endometrium. All the studies they have, which have been describing the subendometrial flows, in all the studies, there is no uniformity on the thickness of the subendometrial zone that they have selected. So we believe in endometrial flows rather than the subendometrial flows. It's also important to measure the flows in the uterine arteries, and the uterine artery PI must be less than 3.2 to have a good endometrial receptivity. And there have been several studies. If the uterine artery PI is more than 3.2, the chances of implantation failure are extremely, extremely high. But remember, the studies must be done before you give HCG, because the moment you give HCG, there's going to be an alloid surge, and with that, there's an increase in the uterine artery resistance, and it remains so for next 48 hours, and therefore your endometrial assessment and the uterine artery assessment will both be different. When we are talking about all the color Dopplers and the B-mode assessment of the endometrium, it's extremely important now then when we have all this volume ultrasound to do a 3D and the 3D power Doppler study of the endometrium to understand it better, because 3D talks about the volumes rather than thickness, and the 3D power Doppler gives you idea not about the vascularity only in one plane that we can assess on your B mode, but it gives you idea about the global vascularity. And this was a very old study. We had presented it in 2006, and it was later on in one of the journals also, and it was a study wherein we decided the time of HCG based on the B mode and the Doppler findings, but in all these patients, before giving HCG, we did a 3D and the 3D power Doppler studies, and we had all those readings on the records. We followed these patients up to their conception, the positive UPT or beta HCG, and also positive pregnancy on ultrasound. And what we found was the pregnancy rates were definitely higher when the endometrial volume was 3 ml or more, and it remained then static and steady beyond 7 ml. The FI was 20 or more, and it again was rising till about 30, and then the VFI also, when it went more than 5, the chances of implantation were a little better. So if you add these parameters to your routine parameters, especially when you have failures of implantation for 2 or 3 cycles, it would definitely open up some of your dark corners, or some of the reasons would be explained for the implantation failures. And there are several studies. There would be no pregnancy when the endometrial volume was less than 3 and the VI less than 10, and exceptionally better pregnancy rates when the endometrial volume is more than 7 and the endometrial VI is between 10 and 35. Then again, if the resistance is low, between 0.5 and 0.57, the chances of conception are good, and the FI, if it is higher, the chances of conception are good. And again, the VFI studies also. So all the studies say that the better implantation possibilities are there when the endometrial vascularity is better. So if I'm just summarizing the features which are important pre-ovulatory features for the endometrial receptivity would be thickness of minimum 6, but preferably 8 to 10 mm, grade A or B endometrium, vascularity reaching zone 3 and 4, covering at least 5 millimeter square area, RI less than 0.6, uterine artery PI less than 3.2, and preferably volume more than 3 cc, FI more than 20, and VFI more than 5. And of course, the pre-ovulatory features, the baseline features, no subendometrial flow, and an intact endomyojunction throughout the cycle. Of course, you can also add to this the assessment of the maximum implantation point, and this is the study which says that if you have a coronal section of the uterus, you draw two lines parallel to each corner, one line parallel to each corner, and where those lines intersect is the line of maximum implantation potential. You measure the distance of this point from the external os, and whenever you are doing your ETs, that is the length of the cannula or the catheter that should be introduced beyond the external os. Of course, we all know whenever anybody is talking about endometrial receptivity, Applebaum scoring needs a mention. Though yes, it was used and it has been approved by a lot of people, but even when the score is 20, it indicates the best endometrium, it is still not 100% implantation chance, because the implantation doesn't depend only on the endometrium. It has multiple factors, you know, the embryo quality and many other micro factors. So actually, we have discussed all the parameters that are involved in that are included in the Applebaum, but we do not personally believe in the actual scoring system. You need to decide for yourself whether you want to use those scores or you want to just exactly assess everything and then make your own decision. Ultrasound with color Doppler still, with the pulse Doppler also have made important landmarks in the endometrial evaluation of infertility and improve the implantation rates. Thank you very much. So then coming to color Doppler in infertility, and as you know, I've already covered the endometrium. That's what I'm going to absolutely exclude from this talk. That's one thing. And the second thing is a lot of things have been discussed on the adnexal and the uterine masses, the uterine fibroids and adenomasses is going to be discussed in the next talk by Dr. Jaideep. So I am going to be a little faster on that and just include the most important points. I'll concentrate on the things which are not going to be covered otherwise. So where would we need a Doppler when we are practicing infertility? Because there are a lot of people who would tell me that, oh, we have a good B-mode machine and we are satisfied with that. Why do we need a Doppler? Is Doppler really required? Should we invest on that? Yes, I believe it should be, because Doppler is a very important modality, and believe me, it can definitely change your pregnancy rates significantly. If you need it for the diagnosis of the pathologies affecting the fertility and for the cycle assessment also. Why for Doppler for the lesions? The uterine and the adnexal lesions have typical vascular patterns, and the Doppler can be of help in their differential diagnosis. I will not go into the IOTA classifications, which has been discussed yesterday, or not how do you do the vascularity scores. I just want to make it as simple as possible for you gynecologists. And if you see a uterine endometrial lesion, we know, and we are again only talking on Doppler, so I'm not going to discuss anything else. So if you are seeing the uterine lesions, you know that a single vessel pattern is typical of a polyp, a peripheral vascularity is typical of a fibroid, a penetrating vascularity is typical of, in the myometrium is typical of an adenomyosis, and if there is a thickened endometrium and there is a regularly placed vascularity, then it is typical of an endometrial hyperplasia. Of course, a heterogeneously distributed dense vascularity is typical of a malignancy. Coming to the adnexal lesions, of course, you may see lesions which are purely cystic, which may have lace-like echogenicities, an iceberg sign or a typical dermoid. You may have lesions which have thick walls with internal echogenicities. And in all these cases, just a word on how you would differentiate the lesions the most easily. Remember, first rule is that any lesion you see in the adnexa, you must try to first correlate it with the physiology. If you are seeing a lesion like this in the in the proliferative phase, I would first think of a follicle, and if you put on a Doppler and it shows a nice flow, peripheral flow, it means it is a follicle, it cannot be anything else. But the same lesion, if I'm seeing in the secretory phase, I would first think of a residual follicular cyst, or even in a very early proliferative phase, I would first think of a residual follicular cyst, and we know that the residual dual follicular cyst may have a very scanty flow or no flow at all. And the third possibility is the simple cyst, but the simple cyst, we know the follicle, if it's a follicle, it's going to regress over a period of 2 to 3 weeks. I mean, in the sense, if it was a follicular cyst, it's going to regress over the period of 2 to 3 weeks. If it was a follicle, it's going to rupture and make a corpus luteum, and if it was a simple cyst, it's going to remain as such. So the second lesson to learn for the adnexal lesion is any adnexal lesion, before stamping it as a malignancy or a complex cyst, it must be observed when examined at least twice at an interval of 2 to 3 weeks, which is in the two different phases of the menstrual cycle. And as Dr. Mamta rightly said, if it persists for 3 months, then it needs an active action. If it is a lesion with a thick wall and internal echogenicities, of course the vascularity is again going to help you. If you see this lesion in the secretory phase, first think of a corpus luteum, put on a Doppler, nice low resistance flow, and it has to be a corpus luteum. And the corpus luteum sometimes may not even present, may have a typical look, but sometimes it may appear just isoechoic to the endometrium. It is only by Dopplers many times that you can pick it up. If it is a hemorrhagic cyst, it will show no vascularity, because a hemorrhagic cyst is not a hormonally active cyst. And again, it may present in any of these ways, because it's ultimately degenerated blood which is inside. And remember, if you have a cystic lesion which has echogenic walls, I'm not talking of the antral follicles like Dr. Mala said yesterday, it's a larger follicles with echogenic walls. And these are most likely luteinized unruptured follicles, and they would not show any flow, or if at all they show flow, it would be a very high resistance flow with an RI of more than usually 0.55. The scattered vascularity at the ovarian hilus and regularly separated peripheral vessels are characteristic of endometriomas. We also call them short-coursed vessels, because these are the vessels which come and approach the lesion, but they do not run along the wall of the lesion. And the reason is not because they actually end there, because we are looking in a single plane. Therefore, these vessels, because they give an acute angulation, they are not seen in the same plane. So they appear as short-coursed vessels on the beam on the regular Doppler, but if you do a 3D power Doppler, they give a typical bird's nest appearance. Dermoids we know can present in any way, but remember, dermoids are avascular lesions unless they undergo a malignant change, or they are atypical for some reason. Infected something. Why Doppler for the assessment of the cycle? Menstrual cycle is a cycle of ever-changing hormones, and still these are all maintained in a perfect balance for reproduction. Imbalance of any one hormone, we know, can lead to complete wrecking of this balance and in turn infertility. And these hormonal changes, they reflect as morphological changes as well as vascular changes, but the vascular changes come first and the morphological changes a little later. So if we can study and interpret the Doppler changes, we can keep a watch on the hormonal change day to day, hour to hour, both in natural and in treatment cycles. This means using Doppler is a better control on your cycle. And this is also soon endocrinology. The hormonal changes occur continuously during the menstrual cycle. Therefore, use of Doppler cannot be defined to a particular day. Though, to simplify the understanding, we would divide our discussion into the baseline scan, the pre-ovulatory scan, and the secretory scan. The baseline scan we have already seen, day 2 or 3 of the cycle. It assesses the ovarian reserve and the response. I want to make one thing very clear here, that the reserve is the capacity of the ovary to produce follicles, that means how many follicles it's going to produce tells you the reserve. And the response is how much push it's going to require. That means what doses you'll require. And the reserve depends on the size and the number of follicles, and the response depends on the stromal flow. So what you're going to assess with the Doppler is the response, and that is going to be very helpful in deciding the stimulation protocols for us. And this is what I think Dr. Vivek has already discussed, but just repeating it to emphasize it, and that is we by Doppler would divide these ovaries into, or categorize these ovaries into a normal responding, a hyper responding, or a poor responding. And the normal responding are the ones which have stromal RI of between 0.6 and 0.7, and the stromal PSV of between 5 and 9, and the stromal FI of between 11 and 14. If you are not doing 3D power Doppler, fine, you may forget about the FI, but still RI and PSV are absolutely important. When the RI is less than 0.58, it is this times that you are afraid. You have to be a little, not afraid, but you have to be a little careful about your stimulation protocols, especially when it is also associated with a PSV of more than 10 and the FI of more than 15. Whereas a patient who has either absent stromal flows or the stromal RI of more than 0.7 and the stromal PSV of less than 5, these are the patients who are the poor responders. They were going to require very high doses to get stimulated to produce the follicles, or to produce the, to give you the good follicles and ova. It is important here to clarify that any one of these three response patterns can be seen in any of the three types of ovaries, which is low reserve, normal reserve, or a PCO. That means any ovary is a combination of, one of the features from the response and one of the features from the reserve. That means a PCO can be a normal responding, it can be a hyper responding or a low responding. Low responding PCO is a resistant PCO. Any low reserve also can be a normal responding, hyper responding, or a low responding ovary. We would not go into the discussion, a detailed discussion of that. Coming to the role of Dopplers in deciding the stimulation protocols, we know that we all have read in the literature that the features which would, or the characters which would decide the stimulation protocol are the antral follicles, the ovarian flow in the form of RI, PSV, and FI, and the ovarian volume and the stromal area in the same order of importance. We would not discuss here antral follicles again because we are only discussing the Dopplers, and it's very interesting to know that the measurement of the ovarian stromal flow in the early follicular phase is related to the subsequent ovarian response in the IVF treatment. Ovarian stromal PSV after pituitary suppression also is predictive of the ovarian response and the outcome of the IVF treatment. This paper by Kopesik has clearly shown that if the stromal FI is less than 11, the patient is going to be a low responder, between 11 and 14 a good responder, more than 15 is an OHSS, but remember this VI-FI, VFI parameters are still not exactly standardized, and you have to find out your own values for your own machines, or your own scanners and your own centers. But if it is low, it is definitely a low responder. If it is high, it is definitely a chance of OHSS. This study again has shown that, of course, there were several studies done earlier on B mode and the routine Doppler, and they had controversial reports. Some said that the PCO ovaries had higher blood flows, and some said it had a lower blood flow, but 3D power Doppler, because it measures the global vascularity, has clearly shown that the PCOs have higher VI and higher VFI values, so it has a higher vascularity. Increased ovarian stromal blood flow in the PCOS may be because of overexpression of the vascular endothelial growth factor, VEGF, which modulates the permeability of the theca cells and increases the insulin-like growth factor 1. It is also because of the LH levels. LH are responsible for the neoangiogenesis, catecholaminergic stimulation, leukocyte and cytokine activation. This means if the LH is high, the stromal flow is going to be high. That is the reason why all our PCOS patients have a higher flow, and they all have an RI of less than, stromal RI of less than 0.58. And But the second finding you find in the PCO is they have a high uterine artery PI, as Dr. Kashyap had already mentioned. And the reason for this is the androgen, because androgen is a male hormone. It leads to increased smooth muscle tone, and the muscularis of the uterine artery is in the muscularis of the uterine artery, there's an increased tone because of this high androgen, and therefore it is a high uterine artery resistance. Because the uterine artery resistance is high, the endometrial blood flow also have a higher resistance, and this is the reason of recurrent implantation and recurrent pregnancy losses and implantation failures in the PCOS patients. This resistance is even higher when the patient is hyperinsulinemic or androgenic. Hyperandrogenic, but it is lower in the obese patients, and this is still not fully understood. Why? I believe it is because of the altered androgen metabolism in the fat. But anyway, that means the higher or the worse form of the disease, the resistance in the ovaries or stromal vessels is going to be lower. We have also already discussed this. I'm not going to repeat that slide. Increase in the perifollicular vascularity of the dominant follicle in the theca layer starts developing as early as 8th day of the cycle, and the fall in the perifollicular RI starts 2 days before ovulation, reaches the lowest at ovulation, remains low for 4 days, and then it gradually rises, reaches 0.5 in the mid-luteal phase. This decreasing resistance can be related to the rise in the estrogen levels. Due to the penetration of the vessels into the granulosa cell layer, increase in the PSV starts 29 hours before ovulation and continues for at least 72 hours. And this can be related to the LH surge. If you look at the diagram of the hormonal changes during the menstrual cycle, you know the LH surge, when it starts, it's a slow slope, and that is about 36 hours before the rupture, and then it suddenly shoots up. And it is this time when, along with the LH, the PSV of the follicle also suddenly shoots up. So that can be, the PSV therefore can be related to the LH. Ovarian flow correlates well with the oocyte recovery rates, and hence may be useful in determining the most appropriate time to administer HCG to optimize the recovery rates, the oocyte recovery rates. And therefore, this vascularity must cover at least 3/4 of the circumference of the follicle. Not only that, these vessels must also have an RI of less than 0.48. You can remember a round figure of 0.5, and a PSV of more than 10 centimeters per second. And this is important in decision making than just the size of the follicle. This is because the oocytes from hypoxic follicles result into a lot of chromosomal abnormalities, and that has been proved in several studies. So if the PSV is less than 10, the chances of getting a grade 1 or a good normal embryo is significantly lower. And this has been proved shown long back in the study by Nagun et al. That if the PSV was more than 10, the chances of getting grade 1 or 2 embryo was as high as 75%, whereas if there was no perifollicular flow, it was only 24%. In today's era, this was a study in 1996 when the color Dopplers were not so sensitive. In today's date, I would say that if there is no perifollicular flow, it's best to wait till you get a perifollicular flow, because the chances of getting a grade 1 or 2 embryo may be as low as even 10%. The vascular changes at the time of impending ovulation include increased vascularity of the inner wall of the follicle and a coincident surge in the blood velocity just prior to eruption, a marked increase in the peak systolic velocity around the follicle in the presence of a relatively constant PI could be a sign of follicular maturity and impending ovulation. This means that if you have a persistently low RI with a rising PSV, this means this follicle is proceeding towards rupture. Whereas there's another important sign which says that if the RI is rising with a steady or a falling PSV, this is a strong sign that this follicle is now not going to rupture, it's going to go into LUF. This means when the follicle is said to be functionally mature, the PSV is 10 centimeters per second, and under the effect of LH, there is a rise in the PSV, and it may reach, it has been shown in one study, it may reach as high as 45 centimeters per second just an hour before the rupture. This means if you are doing your pre-HCG scan and the RI is low and the PSV is not 10, but it is 15, 20, 25, 30, something like that, that means you are now not 36 hours away from the rupture, you are on the slope, that means you are closer to the rupture. Now, based on this theory, we did a study long back again, and what we did was for all those patients who had a PSV of more than 15, for the perifollicular flow, we did 2 IUIs after HCG, one at 12 to 14 hours and another one at routine time, 34 to 36 hours. And we kept a watch and we standardized the rest of the things, the semen parameters. These patients, when they had no other factors causing infertility, so everything else was standardized. And what we found was whether it was a CC stimulation, as you can see here, RFSH stimulation, or at that time letrozole was also available, so it was a letrozole RFSH stimulation. In all these cases, the yellow bars, which indicate pregnancy rate after double IUI, is significantly higher when the PSV was more than 20.
Dr. Sonan, only 2 more minutes.
Yeah, sure. That means if that brings us to a conclusion that if the PSV of the follicle is more than 20 with a low RI on your pre-HCG scan, you need 2 IUIs instead of 1. The earlier IUI helps you to maintain your good pregnancy rates. The follicles with a more uniform perifollicular network are more likely to produce pregnancies, and therefore 3D power Dopplers are required. We again, in the same study that I mentioned in the endometrial presentation, we do the 3D power Doppler studies for the follicles also, and it has been shown that when the vascularity is good, when the FI is, when the VI is between 6 and 20 and FI is more than 35, the chances of conception are extremely high. So if I just summarize all the endocrinological correlations, perifollicular RI correlates with the estrogen levels, perifollicular PSV correlates with the LH surge, and the LH level in the LH surge. Endometrial vascularity is indirect evidence of the adequate estrogen levels. High perifollicular PSV with high uterine atrophy indicates that the LH surge has already started, whereas low perifollicular PSV with high uterine atrophy indicates that it's an immature follicle. In the secretory phase also, the corpus luteal flow correlates well with the progesterone levels. So the low corpus luteal RI less than 0.5 indicates that the progesterone levels are normal, and along with that, if the endometrium has sufficient progesterone receptors, the endometrial blood flows would also, the blood vessels will also show an RI of less than 0.5, with the uterine artery PI is important, less than 2.5. If these are not the features, it may be either a luteinized unruptured follicle or a luteal phase defect. With a luteinized unruptured follicle, you will have a higher RI in the range of, say, 0.5 to 0.6, with an endometrium which is echogenic and shows a scanty flow, but if it's an LPD, it is an even higher RI for the corpus luteum with no flow in the endometrium, and that is the gradient of the RIs in the corpus luteum when in the normal and the LPD, and that is the gradient in the normal and the LPD for the spiral arteries. So color Doppler has now become indispensable for the infertility practice, and 3D and the 3D power Dopplers have significantly added to the value. Thank you very much.
I would be talking on fibroids and adenomyosis, as has been already announced. And I would say that this is one of the commonest gynecological tumors, which has a prevalence of almost to the tune of about 70 to 80% women who have reached the age group of 50. Now, the prevalence increases with age, and it peaks around women who are reaching around 40 years. And hysterectomy samples which were studied in a particular study found that 77% of them had fibroids. Now, it is that common, and most of the time when we are looking at fibroids, sometimes we are really, over abusing the technology and scaring the patient, and then, doing unnecessary surgeries, and many a times also we are also doing a lot of different predictions. I'd like to say here that we normally say that it is an estrogen dependent issue, but progesterone is also very, very important for the growth of fibroids and also adenomyosis. So it's very important for us to see that ovulatory cycles are actually responsible, and when you see that when the lady goes into menopause, then the size of the fibroids or adenomyosis both actually reduce. Now, fibroids can basically, in fact, both of them can come with symptoms of, abnormal bleeding. It could be menorrhagia, it could be irregular bleeding, and so on. And that should be enough an indication for you to go ahead and, suspect something apart from the pelvic examination. Now, why is it important for us to basically locate the fibroids is the next important thing. Now, we have fibroids location, as you can see here in this FIGO classification, all over the uterus, and even in the cervix also. I don't know why FIGO has not taken that into consideration, but this subclassification is important. And locating the fibroid is also very important, because some of them, like especially small intramural fibroids, will have actually no repercussions at all. But the submucous ones definitely need to be picked up, and especially where we are, doing infertility practice, it is a must. Even a small submucous fibroid or a small endometrial polyp will definitely have its repercussions as far as the outcome of any infertility treatment is concerned. And similarly for menorrhagia, it's again very important. Submucous fibroids, the uterine contractility is disturbed and menorrhagia will result. Cornual fibroids, again very important when we are looking at the location, because a lot of times these young girls will come to you with severe dysmenorrhea, and you will say, oh, it's a very small fibroid and it doesn't really make a difference as far as the pain and the bleeding is concerned, but the uterine contractility, we'll understand, again is very much disturbed with the cornual fibroids, and that can lead to severe dysmenorrhea. So that's why maybe a good ultrasound scan is very, very important and is the crux for diagnosing fibroids definitely, and also for the location. Now we have a lot of issues, like we can have a suspicion on HSG or on symptoms, but ultrasound also many a times it will be very difficult to have the accurate location of the fibroid, so we might need an MRI or an IVP, especially when you have very huge size of fibroids. So, and the differential diagnosis could be anything which is there in the pelvis can mimic these fibroids. So why is it now important to exactly look for and report? Now many a times I've seen that the reports when they come to us, it's only written fibroid uterus. Now, most of the gynecologists do not perform their own ultrasounds. So for them, it is very, very important to know where is the fibroid, what is the size of the fibroid, how many fibroids are there, and also the location, especially for the infertility people, what is the association with the endometrial cavity, how much distance is it away from the endometrial cavity. So all these things need to be reported, and what is the blood flow like, because again it will give you a lot of insight into how the growth of the particular fibroid is going to be affected. So when we report or when we look at the size, we look at the shape, we look at the position, we look at the surface, we look at the mobility, we look at the tenderness, because that will give you a lot of, again, insight into whether there's any red degeneration happening or it's an infective process going on. We look at the number of fibroids, we look at the position and size of each, the relationship to the cavity and the endometrium and the tubes. Again, if it is a cornual fibroid, how is it related to the tubes? Because if you're really planning a surgery sometimes, then it becomes very, very important. Then blood flow and the degenerative changes, if there are any. So, and each one, as I have said, has its own importance, and that's why we need to really look into it. I'm just going to show you a few pictures, like you can see here. This could be really normally missed on a 2D scan. Here, a 3D scan, again, importance of 3D for the accuracy is already there. Now, another very important point, or a small procedure which we miss. Many times you'll suspect a fibroid, but you really don't know whether it's submucous fibroid or no. and also how much is it in the cavity and how much is it in the myometrium, because if you are really planning a hysteroscopic surgery, that is of importance to you, and whether it is a fibroid polyp or how thick is the pedicle. So a very small procedure where you can put in a small amount of saline in the uterine cavity, and does not take you more than 5 minutes to arrange for a small, feeding tube or a Foley's catheter, and just put in a saline, and what will happen is that it will line the cavity very well, and you'll exactly know what is the size of the fibroid, how much of it is actually hanging in the cavity, how difficult or how easy surgery is going to be, and how much is it, which you can easily calculate, like you can see here, is actually in the myometrium. Because many times when more than 50% of it is in the myometrium and there's a huge submucous fibroids, then maybe one-step surgery may be difficult. So those are the cases where this assessment really comes in actually handy. Now, how do we really classify intramural and subserosal myomas? We have subserosal myomas where you can see here ones which are pedunculated. You can see that's just a huge fibroid, and that's the pedicle, and that's the uterus here. Now, how thick is the pedicle? Will you have any difficulty? I don't think this is going to be a difficult surgery at all. So we have pedunculated subserosal leiomyomas, which is 0. Then involvement of less than 50% of the outer uterine wall, we'll say grade 1. Involvement of more than 50% of the myometrial wall is grade 2, and leiomyomas that actually extend from the mucosa to the serosa are grade 3. And many a times here 3D will definitely come to your rescue for looking at the accuracy of the diagnosis. Now, what is the relationship of the submucous fibroid with the uterine cavity? Now, this could be very challenging here when you see it on 2D ultrasound. So one thing which will help you is a little bit of saline in the cavity, and the other is where you can do a 3D and you can actually find out that it's not exactly in the cavity, it is a submucous fibroid, and it will has some portion in the myometrium also. Now, that's a panoramic view of a huge fibroid, and again you can see that there are 2 fibroids which are stuck together and may appear as one, but if you do a good scan and 3D, you will know it better. Now, classifying submucous leiomyomas is also very important. We have the grade 0 ones where you have the intracavitary pedunculated leiomyomas, like you can see here on the top, a hysteroscopic picture. Then you have grade 1, which is submucous leiomyomas, which are extending less than 50% in the myometrium, and you have grade 2, which is submucous leiomyomas extending more than 50% into the myometrium, and these are the ones again which will make your surgery a little difficult. Now, can color Doppler really help us? Again, color Doppler helps you in identifying. So many a times polyps will have only a single vessel, which as Sonal has already told us, but fibroids have a different kind of a vasculature, and most of it is capsular, where you'll see a lot of vessels all around the capsule of the fibroid. Now, subserosal fibroids show a lower resistance than the intramural fibroids because of the lesser contact area. And as you see that the malignant changes, the resistance becomes lower and lower, and I think this has already been discussed. Now, the peripheral vascularity, which is very typical of a fibroid, now this is because of the formation of a pseudocapsule, which we have already, I think, has been discussed. You can see here there's a peripheral vascularity, which is very, very typical of a fibroid, and it gives you a lot of indications on how to differentiate it from focal adenomyosis. Because in focal adenomyomas, you will have a vascularity which will be spread all over in the adenomyoma also. So these are just power Doppler pictures of the same. And now, how does color really help us? One thing is that the color helps us in identifying or differentiating between focal adenomyomas and fibroids. And the other is that when you are actually going through a therapy, especially when we are looking at reducing the size of the fibroids where you really don't want to operate, or the patient is not in a stage to be operated, and you have given GnRH agonists or any other drugs where you want to monitor the size. One thing you'll monitor is the size and the other is the blood flow. So you'll see that when we put on gene-rich and agonist, within 3 months, almost about 40% reduction in the size of the fibroid is there, and even also in adenomyomas, and there's definitely decrease in the vascularity also. Now, many times we use it, especially in infertility where we don't want to operate. Once the size is reduced, then you go ahead and do your embryo transfers, and that really gives you a lot of insight into how they are actually behaving. This is just a small uterus where you can see in a postmenopausal women with a fibroid, but vascularity is absolutely nil, and there is nothing much you have to do in these particular patients. Many times you will see lipomyomas which contain very high concentration of fat, and they appear as ecogenic, hyper-ecogenic areas. But they are different from calcifications, because calcifications will always throw an acoustic shadow. But many times you will see calcifications also in myomas of long-standing duration. Now, for infertility practitioners, what is really important? The fertility outcomes are very, very important, and we have seen that definitely there is a decreased fertility outcome when we have submucosal fibroids, and there is recommendation that if there's a small polyp, which is like more than 5 millimeters, or a submucous fibroid, which is more than 5 millimeters or plus, needs to be removed, and the outcome of fertility definitely improves. Now, subserosal fibroids normally do not affect fertility, and if they're small in size, and I would say if they're less than 4 centimeters, they need not be removed. Intramural fibroids again appear to decrease fertility, but the results of the therapy are not very clear. So we really need to do a lot of studies on especially the intramural. The ones which we have said that they definitely have some, the bigger size ones will decrease the fertility. Now, what could be the causes of infertility in these? Now, a thin endometrium overlying the fibroid, which is a stretched vessels, the subendometrial blood flow actually gets compromised. There's less supply to the endometrium, there's difficult implantation, and there's abnormal contractility. As Sonal had very beautifully shown these videos, the contractility of the endometrium is also, or the myometrium is also very important in as far as implantation is concerned. Now, another very important thing which I like to point out here is, like we normally when we see fibroids, we say, oh, you're wanting to get pregnant, and please get this removed because this fibroid will increase in size during pregnancy and it will give you lots of problems. Now, this is a very recent meta-analysis which has actually suggested that the fibroids do not increase in size in pregnancy, and that's again a very important message. There's only one study which has shown that fibroids are increasing in size, but fibroids do affect pregnancy. The smaller ones which you can see like here normally don't have much effect, but the bigger ones which you can see here, the placenta is all over on the fibroid surface, and again that's a huge fibroid in the lower segment, will affect pregnancy in many other ways, and those could be that we could have increased incidence of placenta previa, placental abruption, premature rupture of membranes and preterm birth, and even intrauterine death. But all these, when we put together, the difference between normal and with fibroid is not more than 2%, so which normally is not really considered very clinically relevant. Also, this meta-analysis in 2008 says that with the fibroids, there is an overall increased risk of malpresentations, cesarean section delivery, and also preterm labor. So these are the ways it could actually affect. And as I was saying here, that this study of about 171 pregnant women with fibroids saw that there was actually no increase in size of the fibroids during pregnancy. Now, very rarely these fibroids can undergo malignant changes or leiomyosarcomas, but again the incidence is very low, and that if too happens will happen in the 6th decade or so. Now, coming to adenomyosis. Now, these are two things which sometimes we do get disturbed with. Another thing is that with fibroids, adenomyosis can also be coexistent, but adenomyosis in itself also can be a different entity. And how does it really happen is that when the endometrium actually goes into the myometrium and it does respond to the estrogen and progesterone changes in the menstrual cycle, and you can have a hemorrhage inside the myometrium, and slowly the uterine size increases. Now, the adenomyosis can be diffuse or focal, and we'll see how. Now, you can see here that's the difference between the normal and the adenomyosis uterus. You can see here the hemorrhage happening in the myometrium. Now, the diagnosis can be sometimes very difficult, especially because it is mostly a pathological, or a pathologist can only make this diagnosis, and most of the time one has to wait for a hysterectomy sample to really assess. But you could suspect it by a PV examination where the uterus is very large and feels soft and boggy, on pelvic examination, and can raise a little bit of suspicion. Or when you are doing sonohysterography, and when you actually do this, here what you can see is that there are presence of ill-defined areas of the intravasation which are there, which are actually extending perpendicularly from the uterine cavity into the myometrium, and this is one of the most important features of adenomyosis on a hysterography. But unfortunately, the sensitivity of this technique is also very low. Similarly, on hysterosalpingography also that intravasation can be seen, but again, biopsy is something which will actually give you the exact diagnosis. Now, how do you actually suspect or diagnose adenomyosis? When the diagnostic ability of the transabdominal scan again is a little limited, because the echo texture of the myometrium, what you can see on a transvaginal scan is, definitely much different from transabdominal. So we do rely on only transvaginal sonographic criteria, where you would see a diffuse uterine enlargement, which you can see here. Most of the times, the posterior myometrium is much more thickened. There is an anterior displacement of the cavity. So you'll see here that the endometrial cavity is actually pushed, and sometimes it is so much pushed that it's very difficult to even identify the cavity. And most of the times when you have fibroids and adenomyosis coexisting, it's sometimes very difficult even to identify the uterine cavity. And you can see here that there can be honeycomb pattern of the myometrium, which is very much there, and one or more heterogeneous myometrial areas with very distinct margins with anechoic areas up to 3 millimeters, which we normally call as the Swiss cheese pattern. You have, or a salt and pepper appearance, where you have cystic areas and normal areas interspersed between each other. But the most important thing is that what we need to really study is the endomyometrial junction, which is very, very important. And this endomyometrial junction is actually disturbed. Apart from the appearance of the myometrial cysts or the pseudo-widening of the endometrium, and also poor definition of the endometrial myometrial junction. We will see this a little later also. And the color flow will show you low velocity and low resistance within the lesion. Now, many times we do, MRI, and T2 weighted MR images will actually, in those, the adenomyosis will actually appear as bright foci, or which are seen with abnormal low intensity within the myometrium. They can be diagnosed that way. Now, the ultrasound is actually very operator dependent, and if you can see here the 3D picture, which will actually show you that the margins of the endometrium are very distorted, and the endomyometrial junction is again very much disturbed. You can see here again the cystic areas there. Many times, even myself, I have been really confused. Now, these small cystic areas are okay, but sometimes you'll see a small solitary cyst measuring about 1.5 or 2 centimeters, which actually appears like a cyst in the myometrium, but this is actually adenomyosis or focal adenomyoma, where it's the blood has collected inside. Then how can 3D actually help us? Now, if you see here, you can see these cystic areas in the myometrium, which are irregular, and the junctional zone, the difference between the junctional zone and the cystic areas is not very well defined. And when you see a 3D picture here, you can see exactly that there is a disturbance between the junctional zone and the endometrium and the myometrium, and it's very typical of severe adenomyosis. Now, adenomyosis can also be in almost 80% of the patients be associated with fibroids, endometrial hyperplasia, peritoneal endometriosis, uterine carcinoma, adeno and pelvic endometriosis also exists in about 28%. So when you look at that, you must also look at all the other associated features. Now, just a small description I just wanted to give now how it can actually affect the contractility is also important to understand. So when we see here the circular muscles which are there, the fusion of the paramesonephric ducts, which when it is forming, they form a, this picture is a little bit incomplete, I'm sorry, but they form a, they both fuse together. So you can actually see half of it only. So that's the cornual end and that's the lower part of the uterus. So the fusion is there right in the middle. Now, the contractility of the uterus is very much affected on how these fusion is actually taking place. And once the muscular distension is there at the fundocornual raphe, now this results in formation of the gaps which result in the endometrial proliferation into the dehiscence which is there in the left in the gap areas. Now all this can lead to a very disturbed contractility. Now this can lead to a lot of dysmenorrhea, or the contractility also can lead to implantation problems. And you can actually with video sonography reveal that the uterine peristaltic waves are actually confined to the subendometrial myometrium.
Dr. Malhotra,
Now,
2 more minutes first.
Yeah. So what we are really looking at now for adenomyosis diagnosis is that this is something which is normal, where you can see the subendometrial halo, which is very much visualized. But in adenomyosis, you see that the subendometrial halo is actually not very well defined. The myometrium is thickened ventrally. The echogenicity of the ventral myometrium is decreased, and the presence of myometrial cysts and eccentric endometrial cavity is there, and all this are very diagnostic, and this stria appearance is very, very diagnostic of adenomyosis. Now, there are limitations to diagnosis of adenomyosis, especially when there's a markedly enlarged uterus, not able to, not able to really explore the fundus and the upper body by transvaginal ultrasound. So there you could go ahead and take care, use of other modalities. Now, what are the differences between adenomyosis and fibroids? As I said, there is echogenicity, there is peripheral vascularity, which is very, very characteristic of the fibroids. The subendometrial striations are very characteristic of adenomyosis, and all these can be very well defined by 3D ultrasound. And if you have any issues, then you can actually go ahead and do MRI. Now, symptoms related to adenomyosis, we all are very, very much aware of. Dysmenorrhea is very, very common, and also what is common is that you can have a history of, a lot of pregnancies terminating basically because of the severe pain. So this was a small study which showed that pregnancy termination because of pain and dysmenorrhea because of adenomyosis is much more common than fibroids or any other feature. Lastly, color Doppler in adenomyosis. Now, when is the right time? As nature has provided us that in the periovulatory period, there is maximum blood flow to the pelvis and the adnexa. That probably will give you the best or the optimum time to study the blood flows. And the differences are very remarkable, as you can see here, scattered in adenomyosis and peripheral or capsular for fibroids. And again, monitoring of the treatment, especially with color Doppler and the size, is important, and that can be done very well with ultrasound. Now, adenomyosis is leading to infertility in many various ways. And subendometrial blood flow, as I said, is one of the important affected, and uterine contractility is the other very important feature for those. So we actually look at all the management goals. I will not go into the details and say that both leiomyomas and adenomyosis can be very effectively diagnosed by a well-performed transvaginal ultrasound. Now, color Doppler does and 3D does add a lot of value to the diagnostic ability, and the important feature is that, you know, when you're doing medical management or any other embolization or MRI, the outcome of that management can also be very well studied. Thank you so much for your patient hearing, and I bring you greetings from Agra, and thanks a lot.
Can we have some questions from the audience? Please speak to Mike.
My question is to Dr. Jaideep Malhotra, ma'am. How to go ahead in a patient with recurrent pregnancy losses with no other causes found other than the adenomyoma, and which is a large one and very close to endomyometrial junction.
Yeah, see, for that especially, I would say that if you're really not wanting to operate, then maybe depot injections for agonists for at least 3 months, 3 cycles, you have a 3-monthly depot injection. See that the size is reduced. But sometimes patients do not respond to GnRH agonist. And there, you know, a surgical procedure or an MRI guided focused ultrasound can help. Now, I was just going through the net and I saw that, you know, we normally do uterine artery embolization also, and MRI focused ultrasound surgery. The pregnancy rates with the MRI guided focused ultrasound are much better than uterine artery embolization. And surgery is the last option which we normally take.
Thank you.
Good morning, madam. I want to know that when we suspect an ectopic, we put the color and we see sign ring of fire appearance. So how to differentiate from a ovary follicular flow and flow due to
ectopics are outside the ovary, right? So
yes,
I did not include that.
ovarian ectopic.
Ovarian ectopic is extremely rare. So first thing is don't start thinking of ovarian ectopic. The second thing is the corpus luteal walls are always isoechoic to the stroma. They're usually, 99% I would say they are not hyperechoic, whereas if it's an ectopic, it clearly has the decidual-like hyperechogenicity surrounding the anechoic area, apart from the ring of fire.
And I think your
And
beta
of course,
HCG levels will help you.
Beta HCGs also are high.
Exactly on which day the endometrial receptivity studies has to be done? Which day of the menstrual cycle?
It's not which day, it's pre-ovulatory. So you have seen the follicle has grown to about 16 in the gonadotrophin cycle, 18 in the CC cycle, then you start doing the Dopplers. And the day you are planning HCG, that day the endometrial receptivity is to be done before giving HCG.
Sonal, can I add something here?
Yeah, please.
What I would say that if you are beginning to learn color Doppler, then follow the cycle. Because when you follow the cycle, you will know how and what are the changes which are happening on a day-to-day basis. So we normally say, do it on day 2, do on day 6. When you look at the endometrium, look at the follicle for, the color Doppler, and you'll see slowly that the blood flow is increasing. The peak systolic volume is velocity is actually increasing, and the diastolic is also increasing. So when you watch that, you'll understand yourself. And when you look at the myometrium, what Sonal has already shown us, the myometrial flow, the uterine artery flow, they all increase. So if you're really starting to study, start from day 2 and follow it till the ovulation, or maybe later also, because you'll understand the cycle much better.
Everything you cannot call her every day.
Yeah.
See, you're otherwise also doing your B mode, so you know that I've given CC about day 11, 12, the follicle size is going to be there, so call her on that.
So in a normal follicular monitoring Wala report only, we should add the endometrial receptivity to the normal reporting format itself.
Sure.
I think what we do is we do a baseline scan, and on the baseline scan you mention whether there is vascularity in the subendometrial area. This is extremely important because if sometimes corpus lutea are not seen on baseline, persistent corpus lutea. So if you have a flat endometrium with no vascularity at that point, you're pretty sure that you don't need to do the studies of progesterone, etc., etc. So do a baseline scan, confirm that there is no vascularity, follow it on the day, one day before HCG, because you know, okay, fine, I have to get the husband ready for his sperm sample, and you have to abstain from intercourse. The patient has to abstain for intercourse as well. So what we do is we do it one day before the HCG, on the day of HCG, and I think we are a little different, Sonal. We also repeat it on the day of embryo transfer, and if it does not fulfill the criteria on the day of embryo transfer, we transfer one blastocyst because they do better, and we freeze the rest of the embryos, and we found better pregnancy rates with this. I don't know if it's answered your question, but I think this is a clarity of thought when you're dealing with reporting Dopplers, and I think only Sonal has the real patience, because she was my daughter's teacher, and when my daughter came back from training with Sonal, she would go on and on with the Doppler, and I said, I'm not listening to any more Dopplers from you.
No, but I think the ideal thing which we normally do is on starting the stimulation, day 6, and then on day 9 or 10, depending upon your follicular growth and blood flow studies. So about 2 or 3 scans in a cycle are done.
Yes, doctor.
My question is really to the first speaker. Is there any correlation between polycystic ovaries and increased number of Nabotian cysts in the cervix? And if so, what is the treatment? Thank you.
Increased number of
The first speaker is not there, but I do not think there is a link. However, I have seen many patients, both polycystic and otherwise, having infertility, having Nabotian cysts, but I really cannot answer that question. I don't know if my colleagues can answer that.
No, I have no.
But it's something nice that you've said, because now I'll start looking, and maybe the next meeting I would present this data, but I can't answer that question just now.
Good morning, ma'am. My question is like, I fail to understand why still there is so much of emphasis on uterine artery PI in endometrial receptivity scan, when we know that uterine artery gives a global supply to the uterus, which is major. I mean, the major component is the myometrium, and a very small component is the endometrium. And once we are already looking for the subendometrial and endometrial flow, then why not just stick to the subendometrial and endometrial flow and avoid taking the uterine artery PI for the sake of the time, and especially if there is any fibroid or any adenomyosis, is going to alter the PI altogether.
You are absolutely right. You are absolutely right, and I take this point positively. Yes, that is very true, and it has been shown in several studies. We have also observed that whenever there is a fibroid or adenomyosis, or for that matter, any large lesion in the uterus, the uterine artery resistance is going to be lower. And you may sometimes falsely think that the uterine artery resistance is normal. Of course, it's only adding. When you're already seeing the endometrial and the subendometrial flow, it's adding one more parameter to be a little more sure, because the earlier studies were all on the uterine arteries, were not on the subendometrial flows.
Can I answer this question? I just have one take-home message for you. Don't try to understand a woman, her uterus, or her baby. It's very dangerous.
Ma'am, one more query I have. I'm a radiologist, but of late I am more involved in the fetal medicine and the reproductive medicine. So, of my experience and of our seniors' experience, we have seen many times the hydrosalpinx, the classical way which we project and we don't get in our real-time practice, and many variations of hydrosalpinx which we keep getting, especially in cases of pelvic adhesion, endometriosis, and so on. And the one pattern which I fail to understand, why there is intermittent appearance. Sometimes we have seen in some part of the cycle we have seen the hydrosalpinx, and some part of the cycle we have not seen this hydrosalpinx. And when our boss is going to do the embryo transfer, and suddenly he sees the hydrosalpinx and he bounces back that, why didn't you report this hydrosalpinx? And I just had a look at the literature and I found sometimes hydrosalpingo simplex and follicularis, some classification, it may be functional obstruction, which may resolve, like
The first answer, I go to your answer one by one. I had just made a statement, don't understand a woman, her uterus or her tubes, and definitely not her ovaries. We must realize that a woman secretes all the time, and she secretes into the fallopian tube as the estrogen levels are going up. And if it is a non-communicating hydrosalpinx, then sometimes the secretion gets retained within the hydrosalpinx, and it becomes obvious during stimulation. If it is a communicating hydrosalpinx with the uterine cavity, then you would see that fluid in the uterine cavity during the course of stimulation. So please tell your boss that he needs to look at the uterus as well. If it is closed, it is open partially at the tube, at the tubal end, that is a femoral end, then you may not see it until you're very late in stimulation. So I think more than classifying it into simplex, complex, and so on and so forth, it's just that your tube is open, communicating, non-communicating. This is on a personal level. I have no data to support this. And when I suddenly see a hydrosalpinx during ovum pickup, I don't inform anybody else, because as a gynecologist, I do my own scans.
To that. And this is a very common finding. Many times hydrosalpinx, they drain themselves on their own, and it's surely communication with the uterus.
And one more question, ma'am. Like when we are seeing a pattern of polycystic, because they can have varied presentations as we know, and the Rotterdam classification keeps changing from the magic number 12 to 19 to 23, it goes on. So the practical issues which we face is we have to say whether it is polycystic or not. Then wouldn't it be prudent to call it polycystic ovarian morphology rather than polycystic ovarian, because we are not taking phenotypic and biochemical things into
Absolutely. But as a radiologist, I think when you're doing a transvaginal scan, most radiologists look at the surface anatomy of the woman, and if she has acanthosis, hirsutism, and she's large, and you get put off, you're rest assured she's polycystic. So she has polycystic ovarian syndrome at that time. So I do think that as radiologists, you're also not only looking at the imaging, but you're also looking at the person in general. So I do think that it is only when she's thin and does not have the typical phenotypic feature that you can call it a polycystic ovaries, but take the history, and I think in our reporting standardization, we have to write the reason of referral. So if the reason of referral is irregular cycles, the phenotype is that of a typical polycystic, and you see a polycystic ovaries and all the features, Rotterdam or otherwise, it is mandatory that you mention it as a polycystic ovarian syndrome. However, if she does not have the phenotypic features and you don't know why the patient was referred to you, then you can write it as polycystic ovarian morphology.
What is important is not the volume and the number of follicles. It's more important to look at the stroma, the echogenicity of the stroma, and the vascularity of the stroma.
But then, ma'am, they have avoided this as a criteria, that stromal echogenicity,
Yeah,
because it is very intra-observed.
But Rotterdam is pretty old now. There are a lot many papers, new papers on PCOS. You can just open the net and go through, if I'm not wrong. There's several of them, and most of them have mentioned the stromal abundance as a very important feature. But Rotterdam is very old now. Even we are not following the Rotterdam anymore.
But Sonal, for diagnosis, I think it's still important for them to, have a
but even if the volume is normal, I have not shown that presentation to you because that's not the topic, but even if the volume is normal, even if the number of follicles are 12, even if you go to Rotterdam, what does it say? The ultrasound features of Rotterdam is ovary which is 10 cc and or has more than 12 follicles, and then two of the three features. That means the ovary may be absolutely normal and still it's a PCOS. Yeah. There may be an ovary which is 10 cc but less than 12 follicles and still it's a PCOS. Right. And there's an ovary which is normal size or less than 10 cc in size and more than 12 follicles, then also it's a PCOS. So what is more important is not the size, not the number of antral follicles, it's the stromal echogenicity, which tells you that the LH is high,
And the androgen is high, it's the stromal vascularity which tells you the LH is high, and it's basically the LH and androgen which are the culprit for the PCOS. So
These
look
are
at
all
the stroma.
variants of
Don't you think there is
PCOS.
intra-observer?
Don't like, as a radiologist, let me tell you, you don't have to report PCOS unless the ovary is clearly more than 10 cc, there are more than 26 follicles according to the new papers, and the stroma is echogenic. Otherwise, just report as polycystic ovaries correlate clinically for the diagnosis of the syndrome.
See, PCOS is a clinical diagnosis.
Exactly,
With
that's what.
PCOS,
You can only
as
report a
radiologist-
PCO.
As a radiologist, you have to report upon the ovary. You can call it a PCO ovary, or as ma'am has said,
Yeah.
correlate clinically. So PCOS is.
So basically, you have to write polycystic ovary
PCOS is
morphology,
not a
basically.
radiological diagnosis.
Yeah,
Yeah,
very
okay.
right.
It's a syndrome.
If one of the ovaries is normal sized, 6-7 cc,
Yeah.
and the other ovary is around 10 cc, and there is no increased stromal echogenicity on either side, and the number of follicles is more than 12 on both sides. That's multicystic. Then
If the stroma is not hyperechoic, it is not abundant, that means it is multicystic, it's not a polycystic.
And that's quite common in,
ovaries is more than 10 cc and more than 12 annual follicle count is there on both the sides.
But if the stroma is normal, it is still a polycystic, multicystic. If at all, along with that, she has hyperandrogenism, biochemical or clinical, or she has oligoanovulation, only then the clinician will decide, okay, it's a PCOS.
We should report it as multicystic rather than polycystic.
Sure. And the best way is when you're confused, write the complete description and say it looks like this and clinical correlation, because these are all syndromes. These are not just ultrasound or a radiological diagnosis.
Thank you for the very informative session. I have two questions. Do you use SIS for tubal patency? Or can you tell in short about the material and methods we use for SIS?
We'll answer one question at a time. Number one, I do not use it for tubal patency, though it can be used. Because we are not looking at patent tubes, we are looking at functional tubes. And I do not think that SIS is going to help you to assess the functionality. It just tells you whether a tube is patent or not. So personally, on a personal level, I don't, but it can be done. The second question is that we use it only to evaluate the uterine cavity. I know Jaideep is waiting restlessly to answer that because she does a lot of SIS for tubal patency. I'll give you the mic in a moment. As regards to how you do it, we do not do it with a Foley's catheter for a simple, straightforward reason that if you're having any abnormalities in the cervical canal or slightly above, the Foley's bulb actually obscures it. So what we do is we keep things as simple as possible. There are specialized, there are catheters that are available in the market, the sonohystro catheters that are available. They are a little expensive for a very simple procedure. We limit that use when we want it in the real sense. On a day-to-day basis, we do SIS for all our patients, and what we do is we use an ordinary IUI catheter. The ideal one is the outer bulb of a Labotec catheter. This is on a practical level. We use the outer bulb because it has that little enlargement at the bulb, so we use that, and it's very easily traceable on ultrasound, and we instill about 5 ml of normal saline into the uterine cavity very, very slowly, and while we take a quick 3D sweep of the picture and put it for analysis at a later time. I'm going to hand this over to Jaideep, who's waiting so restlessly to answer your question.
no, I would just say that we do it regularly, but it is a first investigation for a young couple who walks in. Because I'm not only talking about the tubes when we do this, because it gives you a lot of other information about the uterus, about the cavity, about the tubes, about the adnexa, about the ovaries. So as a first investigation in a young couple, I would definitely recommend it. Because the other added information is much greater than any other modality.
I think a HICO-C is much better for that, particularly because if you have a patient who has a frozen pelvis, this is the only place I may agree with the protocol that you use. If we agreed on everything, both of us are not necessary to be here. So I think what we do is a hypo-C is important in a patient with a frozen pelvis, where you know that you cannot access the tube very well, and you want to know whether it's patent at the fimbrial end or closed before thinking of a Assure to block the cornu, or tubal clamping at the medial end before we do an IVF. So maybe a hypo-C at that point in time may be the ideal scenario, but it's very expensive, and I don't know whether it's available, though Sonal says it is available. This could be the only application that I would use for tubal evaluation. Sonal, on this?
Thank you.
You comment?
Ma'am, recently we also wanted to start this hypo-C, but then I found a presentation and a lot of papers on the hypo-C now coming on, like histosalpingo-foam sonography.
Yes.
And we have already in the process of starting that procedure, because it adds a lot of more information and it's available, easily available, and there are a lot of other benefits also being a dynamic scan.
Sure, it's you may call it a hypo-C, you may call it a hypo-C. It's
Hypo-C is foam.
foam, I know, but when we are using this also, we are creating a foam inside.
No, but then the availability.
The contrast is different. The contrast is different. But basically the procedure is just the same.
It's more cost effective than
Yeah, sure.
See, initially when we used to do, I don't know, with betadine, and what betadine used to do, we used to create foam, and air is always better visualized. So we used to, very long time back, I had presented papers where we would, instill a mixture of betadine and saline, and that used to create a lot of foam.
I think,
Just one question.
last question, please.
Very frequently we see subendometrial cysts in the upper part of the cervix. So what is its importance on TVS?
Shall I answer?
Mostly, endocervical cysts extending up.
They're all
segment.
internal Nabothian cysts.
Yes, sir.
Like what we see external, something like internal Nabothian cysts that don't require any treatment.
Yeah. There's nothing much you can do about it, but it does tell you that maybe chronic cervicitis is there. So you need to look at the other features on echogenicity of the cervix and all.
No, one thing is very important here. You must understand that as a radiologist, when you comment upon that, or as a sonologist or a gynecologist, they are the most dreaded thing which we can find on an ultrasound. Because once we want to do an embryo transfer, our catheter will get stuck at that particular point. So you must look at the such Nabothian follicles or any cysts which you find there, and and map them. And when you report, must map properly and draw something so that the gynecologist knows that there is a problem.
Yeah.
Yeah.
Thank you so much.
Okay,
I think canal, when you just look at the canal along with it, it's much important.
Very important.
Yeah.
Just last comment.
One last comment, can I please, Dr.
Yeah.
This is the time for introduction you saved when you had to introduce me. I think I must tell you, I'm very grateful to a very sweet, on behalf of my colleagues who are standing here as well, that I think you're such a sweet audience to sit so much and avoid your coffee. Thank you, chairpersons.
Yeah. Thank you. The last comment, the first talk by Dr. Vivek was that he compared waist of a woman with some pathology in the pelvis in the form of hydrosalpinx. I think there are many better things that we have to find out to compare the waist, and let us give it a big round of applause to all these poor people for this marathon session of 2.5 hours in the morning.
Good afternoon, everybody. Today I've been asked to talk to you on risk assessment of endometrial carcinoma with IETA approach. Now, a few words about endometrial carcinoma. The most important thing is that it is the 4th common cancer in women, and I was surprised to see that it is common than cervical cancers, and the incidence is almost 1 in 2,000 over the age of 50 years, and usually presents as a postmenopausal bleed, and the risk factors are overweight, unopposed estrogen secretion, and family history. So this is briefly about what exactly endometrial carcinoma is like. Now, there are certain typical presentations which we come across in our day-to-day practice. This was a 50-year-old postmenopausal lady who was sent to me with 2 bouts of postmenopausal bleed. And when I did the scan, the transvaginal ultrasound, sagittal section showed that there was a large irregular hyperechoic area with interruption of the endomyometrial interface, which was looking very much like an endometrial carcinoma. Then we switched on the color Doppler, which shows that there was sparse vascularity, but still there was vascularity of the endometrial lesion. And we did an endometrial biopsy, which revealed the pleomorphic changes, and then subjected the patient for surgery and hysterectomy, where we could find that there was a cauliflower-like growth within the uterine cavity. So this is the typical presentation which we come across in our day-to-day practice. Now, there are certain presentations where there could be some amount of dilemma, clinical dilemma. As you can see in this particular patient, she was a 48-year-old postmenopausal woman who had only one spell of spotting about a few days before she came for the scan. And this was the transvaginal sagittal section of the uterus, which showed that there was a thickening of the endometrium, but the endomyometrial interface was not interrupted. Then we naturally, whenever we have this sort of patients, we definitely start using color Doppler, and the color Doppler showed that there was intense vascularity. So here, morphologically, there was an endometrial thickness, but the echogenicity of it was slightly hyperechoic, but the endomyometrial interface was intact. And at the same time, but the color Doppler showed that there was intense vascularity. So we subjected her for diagnostic hysteroscopy, which revealed that there was a polypoidal growth projecting into the uterine cavity. The biopsy revealed that there was pleomorphic changes, and hysterectomy showed that there was a papillary growth within the polypoidal growth within the uterine cavity. So these are the overlapping features with diagnostic dilemma. Similarly, another patient who came to me, she was only about 49-year-old with no bleeding, but then she was having some sort of secretions which were there. So we subjected her, the transvaginal scan showed that there was definitely increased thickness. Only one point which was bothering me was that there was some amount of hypoechoic area which was seen at the periphery, which we felt that there could be some amount of fluid there, and then we had a doubt whether it was a polyp. So but then on color Doppler we found that there was a intense vascularity, and we subjected this patient for saline infusion histography, which showed that there was a long, elongated, well-defined polyp which was clearly delineated by SIS, that is saline infusion sonography, and then we subjected her for hysteroscopy, which diagnostic hysteroscopy revealed that there was a polyp. So these are very difficult, different types of presentations which we come across with overlapping features, which can be confused for malignancy, or it could turn out to be a benign lesion but turns out to be a malignant lesion. So these are the things which we have to keep in mind, and this sort of problems can be overcome when we have a definite approach, like whenever we have a patient presenting with postmenopausal bleed, a transvaginal examination is mandatory and requires clear understanding and correlation between the ultrasound features and pathology. Pertinent diagnostic tests such as saline infusion sonography or gel infusion installation sonography or a hysteroscopy, diagnostic hysteroscopy, have to be done, and appropriate biopsy techniques should be followed, and flow charts are extremely important, and which is going to be extremely useful. As I take you through the talk, I'll show you how important it is to go through the flow charts. Now, and to make our lives much more comfortable, the IETA, that is the International Endometrial Tumor Analysis Group, has published an article in 2010. One of the authors are there with us, that is Elizabeth Stein is there with us, who is also an author for this document. They have given certain terms, definitions, and measurements to describe the ultrasound features in order to identify these endometrial carcinomas. Now, the first and foremost thing what they have asked us to do is to evaluate the endometrial thickness and endometrial morphology, evaluate the vascularity of the lesions, and then also do a saline infusion or gel installation sonography in order to make out the outline of the lesions. So this is the approach that has been suggested to us, and I just wanted to project this slide because I wanted to show the impact it has created as one of the white journals, that is May 2014 white journal, had 6 articles on endometrial carcinoma and various applications in diagnosing this particular problem. So with this, I'll take you through the factors which have been, which we are going to evaluate whenever we have a postmenopausal lady or a lady with an endometrial thickness, where we need to evaluate the quantitative assessment of the endometrium, then the qualitative assessment of the endometrium, endomyometrial junction, color and power Doppler of the endometrium, and the color score which is subjective, and do a saline infusion sonography or gel installation sonography, and the gold standard is the transvaginal examination. So through the transvaginal examination, we need to evaluate all these factors which have to be answered. Now, AITA has defined certain terms which are extremely important to understand, and it is there in the journal which is available, and you can go through the journal, which tells us about the echogenicity and its uniformity, non-uniform echogenicity, endomyometrial junction, vascularity of the endometrium, color scores of the endometrial vascularity, and saline infusion sonography or gel installation sonography to outline the lesions and to define the lesion, and at the same time the endomyometrial interface. So keeping this in mind, let us start evaluating the endometrium by evaluating the thickness or the quantitative assessment of the endometrium. For that, the most important thing is a transvaginal sagittal section of the uterus. Quite often you need to magnify the image in order to evaluate the endomyometrial junction very clearly. You put the calipers on either sides of the midline, that is the magnified image, measure the thickest part of the endometrium perpendicular to the endometrial line. And then in cases where we find some amount of fluid within the cavity, we need to take the endometrial thickness, adding or summing up both the walls. Whenever there is an irregular endometrial thickness, you need to take the AP and anterior and posterior thickness of the mass, and then add it up to give the endometrial thickness. And when the endometrium is not clear, it should be reported as non-measurable. This is an extremely important factor which we should remember, that in some of the cases we may not be able to really delineate the endometrium, and at the same time you find that the endometrium is thick and irregular. So these are the typical examples where we have a magnified image of the sagittal section of a transvaginal uterus, where we could find that the endometrium is very clearly delineated. You need to take the thickest part and measure with the opposing calipers just perpendicular to the endometrial line. Whenever there is a fluid, you try to add the anterior and posterior thickness. And whenever there is irregularity also, you do the same thing. And this is a typical example where we have an unmeasurable or non-measurable endometrium which cannot be delineated very clearly. So that is regarding as far as the endometrial thickness is concerned. Now, okay, we have now understood that this is how we have to measure the endometrial thickness, but then what is the clinical implication of it? We may have endometrium which is less than 4 or 4 millimeters. In that situation, we don't need to do anything. But whenever we have an endometrial thickness which is about 5 millimeters, the possibility of endometrial carcinoma is only 1%. So these are the patients you don't need to do any endometrial biopsies. You need to ask them to come back for follow-up. Whereas whenever we find the endometrial thickness is more than 5 millimeters or 5 millimeters, these are the patients where the endometrial carcinoma incidence is almost about 10%, and the biopsy is mandatory. And in situations like this, where we have an unmeasurable or non-measurable endometrium, in these situations, it is essential that there is a high incidence of cancer and endometrial biopsy has to be advocated. So this is the approach based on the endometrial thickness. Now, coming to the qualitative assessment of endometrium, that is what is called as the endometrial morphology, we go by the endometrial echogenicity, endometrial midline, as well as the endomyometrial junction or the junctional zone. Now, taking the echogenicity of the endometrium into consideration, we normally compare it with the echogenicity of the myometrium. It can be isoechoic to the myometrium, it could be hypoechoic, or it could be hyperechoic. Quite often in our practice, the endometrial echogenicity in an endometrial carcinoma is either hyperechoic, or we may have lesions which are mixed echogenic. So this is the typical presentation. So we have an endometrium which is thickened more than 5 millimeters. We have an echogenic or a mixed echoic endometrium which is to be kept in mind as far as the morphology is concerned. Now, coming to the endomyometrial junction, the most important thing is interrupted endomyometrial junction. This is a very important thing where you really cannot get the endometrial junction, endomyometrial junction in toto. Only areas of endomyometrial junction are seen, but the rest of the areas are interrupted. So this is a typical interrupted endomyometrial junction. Now, coming to the vascular pattern, it may be a single vessel which is supplying the endometrium, which is thickened, or you may have a multiple focal lesions which are supplying that particular lesion, or we may have multiple global lesions which are diffusely and intense vascularity can be seen, and rarely you may even find a scattered vascularity as you can see here. So these are the different patterns of vascularity that you can appreciate as far as the endometrial vascularity is concerned. Based on that, even the color scores can also be done. Now this is a very important sign which has been described by Timmerman, which is called as the feeding vessel sign, in which you can see a vessel supplying the endometrium which is thickened. It is predictive of a focally growing lesion, and it has a high positive predictive value but low negative predictive value. Actually, this slide I have borrowed from Elizabeth Epstein, and this is from her talk that I took it, and it's very, very rarely we find this sort of beautifully demonstrated sign. Then we have a saline infusion sonography which can reveal the nature of the cavity. This particular one where we introduced the catheter and we started putting the saline into the cavity, where we can see that the cavity is getting filled up with the fluid, and now you can gradually see a mass which is seen very clearly, and in this mass, which is actually heterogeneous or even a mixed echoic, because there are certain hyperechoic areas and cystic areas within the mass, and you put the color Doppler on, you find that there is a feeding vessel which can be seen draining into the mass, so which is a very typical feature of a increased vascularity, which is suggestive of plausible malignancy, and this is a typical case where we have a focal vascularity of the lesion which is seen as encroaching into the uterine cavity. Now, there has been a flowchart which has been designed by Elizabeth Epstein in 2002, where she has categorized them as endometrial thickness more than 5 or unmeasurable, in which sometimes we find in our practice that we may have a globally thickened endometrium, where you put a saline infusion and you can demonstrate that the endometrium is uniformly thickened throughout. In this situation, what we do is we try to do a simple endometrial biopsy. In case sometimes we may get into a trouble like saying a failed endometrial biopsy or insufficient sample that has been taken, and these are the patients who have to be subjected for diagnostic hysteroscopy. Similarly, when we have an endometrium which is thickened, but you do a saline infusion sonography and confirm that there is a possibility of a polyp which is seen along the anterior wall of the cavity, and the vascularity is not very much. So this looks more like a benign polyp, and these are the patients who have to be subjected for operative hysteroscopy, so that we get we have the treatment also done. Then in certain situations like unmeasurable or interrupted endomyometrial junction, these are the patients where we need to do a color Doppler, and when you find increased vascularity, subject them for, that is what is called as the feeding vessels, and then subject them for operative hysteroscopic biopsy so that we get the histopathological diagnosis. In these situations also, sometimes it could be inconclusive, as you can see here, and in these situations we need to do a diagnostic hysteroscopy and do an endometrial biopsy. So this is how we have to approach a patient with globally or uniformly enlarged or thickened endometrium, endometrial thickness more than 5 millimeters which is focal, or endometrium which is unmeasurable. So this is how we have to approach these cases. Now, after listening to all these things, the features which we are suggestive of an endometrial carcinoma are mixed or hyperechoic endometrium, echogenicity of the endometrium, irregular interrupted endomyometrial interface, multiple densely packed large irregular branching vessels, and then high vascularity score. These are the ones which are suggestive of an endometrial carcinoma, and saline infusion sonography shows that there is an irregular surface. So these features are extremely important, but more than that, the most important parameter is the endometrial thickness. Endometrial thickness which is more than 5 millimeters have to be considered for further evaluation in all these cases. Along with it, you depend upon these associated features like echogenicity, vascularity, vascular scoring, as well as the saline infusion sonography. Now, we have to grade the endometrial carcinoma. Why should we grade the endometrial carcinoma? The reason is that if you can grade the endometrial carcinoma, we can diagnose them early. If you diagnose them early, the incidence of death is only 4%. The recurrence rates are very rare, and then there is no myometrial or cervical invasion, and then there is no distant metastasis and lymphadenopathy. Simple hysterectomy is the treatment of choice, and there is no need for any radiochemotherapy. That is the reason why we need to grade these endometrial carcinomas so that we can give them a better prognostication. Now, invasions, as far as the invasions are concerned, we have two types of invasions that we can come across. One is the myometrial invasion, the second one is the cervical invasion. When we talk about the invasions, it can be assessed both subjectively as well as objective parameters can be taken into consideration. The multimodal strategy is more effective in preoperative distinction or detection of high-risk endometrial carcinomas. This has been suggested by Epstein et al. In 2014, saying that preoperative histology plus ultrasonography improves the detection by about 81%. Same thing has been stated by Orthoff et al. But then the approach was different, that the multimodal approach was that they did a hysteroscopic dilatation biopsy plus MRI for preoperative prediction. So whichever the modality you would like to depend upon, you can take that take it into consideration in preoperatively assessing the invasions. Now, the objective parameters as suggested are that you need to take the endometrial thickness, as you can see here, and also take the tumor versus, or the ratio between the tumor and the AP diameter of the uterus, and then you have to evaluate the minimal tumor free margin, and you can even use the 3D tumor volume as well as the volume of the uterus and take the ratio between them. So these are all the various parameters which objectively tells us regarding the invasion of the myometrium. Now, coming to myometrial invasion, as I said, these are the parameters which can be depended objectively. What we need to do is we need to evaluate the diameter of the AP diameter of the uterus as well as the AP diameter of the endometrial lesion. The endometrial lesion, diameter of the endometrial lesion by the diameter of the uterus, if it is more than 50%, we have to strongly suspect the possibility of a myometrial invasion. That is one. Second thing is regarding the cervical invasion, it is very important to objectively assess the distance from the outer cervical os to the lowest margin of the tumor. If it is more than 2 centimeters, then if it is less than 2 centimeters, it definitely is highly suggestive of possibility of a cervical invasion. Another important thing is you can even do a dynamic evaluation, and this dynamic evaluation is done by what is called as the sliding sign, where the bulging tumor, if it is a bulging tumor, it slides, whereas if it is an infiltrating tumor, it does not slide along it. So not only that, whenever there is a invasion, cervical invasion, the vascularity of that region will be very high. So we have a typical case here. This patient, we have seen that there was a large growth in the endometrium, which was protruding into the cervix, and it was bulging the cervix. But then when we did the dynamic evaluation, there was no sliding. And when we did put the color Doppler on, we could see an intense vascularity at that region. So this is a typical example of a cervical invasion, which has to be confirmed by doing these things. Now, Duham et al. Have suggested a risk of endometrial carcinoma assessment, where they have taken 9 parameters into consideration. One is the obesity, that is by taking BMI into consideration. Each point is scored as 1, and endometrial thickness about 10 millimeters, endometrial thickness more than 15 millimeters, presence of vascularity, presence of multiple vessels, presence of intense vascularity, and interruption of the endomyometrial interface through the saline infusion sonography, and irregularity of the outline. These are the factors, 9 factors that have been taken, and whenever the score is 4 or more than 4, including a saline infusion sonography, the possibility of malignancy is very high. If you are not doing a saline infusion sonography, if the score of 3 also, we have to strongly suspect the possibility of endometrial carcinoma. So this is what is called as the risk of endometrial carcinoma assessment suggested by Duham et al. Now, to summarize, the endometrial thickness of less than 4, no further investigation is required. Unmeasurable endometrium should be evaluated, and vascularity of the endometrium and color scores help in grading the lesion, and saline infusion sonography and gel installation sonography outlines the lesion and its surface irregularity. Endomyometrial junction helps to identify the focal lesions, and above factors help in planning appropriate sampling technique, and preoperative assessment of myometrial and cervical invasion is effectively done by ultrasonography. Now, the points that have to be taken home are that the transvaginal ultrasound is the imaging modality of choice, and IETA guidelines have to be followed in order to appropriately diagnose these endometrial carcinomas. Not only that, you can also pick them up very early, and early diagnosis, as I said, is much more, gives a better prognostication. And not only that, we're using this risk of malignancy scoring, we can come to a very reasonable conclusion about the stage of malignancy, and saline infusion sonography and gel installation sonography are very important in diagnosing lesion irregularity, and flow charts are extremely useful in managing these patients. And there are certain newer techniques like elastography as well as contrast ultrasound, which are going to be of great help in evaluating these lesions. So I think with this, I would conclude my talk, and I would also invite all of you to ISUOG 2016, which is going to be at Hyderabad between May 6th and 8th next year, and you're all invited. And then the registration counter is already open at this conference. Thank you very much.
I'm going to talk about 2D and 3D ultrasound in the assessment of cervical cancer. I will talk about the accuracy of ultrasound and MRI in the assessment and staging of early cervical cancer. Will 3D improve the assessment? What does a cervical cancer look like on ultrasound? And how should we perform the scan when we assess the extension of the tumor in women with cervical cancer? And finally, I'm going to give you some case examples where we can help each other to look for the tumor. The staging according to FIGO is not very accurate. We know that in early stages, about a third of the cancer will be wrongly staged, and for the more advanced stages, about 2/3 of the women will be wrongly staged. Still of today, according to FIGO, imaging is not compulsory in the diagnostic workup of women with confirmed cervical cancer. However, they suggest us to use imaging to tailor treatment. Still, there is no consensus on which imaging modality to use and that provides the best accuracy. And there is also a limited availability worldwide of some of the imaging techniques, such as, for example, MRI. I believe that ultrasound is still undervalued and underused. According to the American College of Radiologists, they only gave ultrasound a score of 2, which is considered non-appropriate, but CT and MRI a score of 8. And I'm going to prove to you today that this is wrong and should be re-evaluated. We know that staging is of a high importance to women with cervical cancer. Because women with small tumors of less than 4 centimeters with no parametrial invasion, they can be offered surgery. In fact, they can also be offered fertility-sparing surgery, trachelectomy, in case of the tumor being less than 2 centimeters and there being a distance of more than 1 centimeter from the cranial margin of the tumor to the inner cervical os. Whereas women with tumors of more than 4 centimeters with parametrial invasion or with bulky nodes, they should be referred for radiochemotherapy. There are some studies comparing ultrasound and MRI. 2 colleagues of mine separately conducted studies. They found that, Daniela Fischer-Roma found that ultrasound was slightly superior to MRI when it came to detecting tumors, partly because ultrasound was a better modality detecting small tumors of a size of less than 1 centimeters. In the study by Antonia Testa, there was no significant difference in between ultrasound and MRI, either for tumor detection or for detecting deep stromal invasion. So we did a study together, me, Daniela, Antonia, and another guy from Lithuania. We found that ultrasound was significantly more sensitive and have a lower false positive rate when it came to detecting tumors. We also found that ultrasound was slightly better than MRI when it came to assessing parametrial invasion. What about ultrasound and MRI? Will they be able to detect the lymph node metastases? In this series of 182 patients, 20% of the patients had lymph node metastases. Preoperatively, only 3 of these women was detected by ultrasound and 4 by MRI. In fact, most of these lymph node metastases were micrometastases in seemingly normally sized lymph nodes. In one of the sites in Lund, where I used to work, they used a sentinel node technique in the beginning of the surgery. In this case, they selected all but one lymph node prior to surgery, so that there was only one woman that ended up with a positive lymph node postoperatively. So the conclusion here is that ultrasound and MRI are both highly accurate techniques for the preoperative assessment of women with early stage cervical cancer. Ultrasound may still be more accurate in detecting small tumors in assessing parametrial invasion. And there is today no imaging technique that adequately can detect all lymph node metastases. Perhaps the sentinel node technique is a way forward. What about 3D ultrasound? Will it improve the assessment? We did a study on 3D ultrasound to determine how well it correlated with advanced disease. We found that 3D volumes correlated to deep stromal invasion. Still, subjective assessment based on the 2D image was superior to the 3D volume, irrespective of cutoff. We also found that the 3D vascular indices were of no value in the prediction of lymph node metastases and deep stromal invasion. In fact, the bigger the tumor gets, it also gets more necrotic in the center, and also small tumors are highly vascularized. This could be one of the explanations. In a recently published study by Chiappa and co-workers, they compared 2D and 3D multiplanar assessment of cervical cancer. And they found that both 2D ultrasound and 3D ultrasound had a comparable accuracy, and it performed as well as MRI. So, what does a cervical cancer look like on ultrasound? We did a study to determine the sonographic appearance of cervical tumors. We wanted to see if there was any common features among adenocarcinomas and squamous cell cancers. The first conclusion from this study is that adenocarcinomas are more often isoechoic as opposed to squamous cell cancer. Therefore, adenocarcinomas might be more difficult to detect while using ultrasound, whereas the squamous cell cancer are more often hypoechoic. Here we have 3 cases of cervical tumors. See if we can get this to work. You can all see that it's quite difficult to delineate the tumors using only grayscale ultrasound. When we put on color Doppler, we can see that there are regions in these surfaces that are more vascularized. So the second conclusion from this study is that also in isoechoic tumors, we can have great help from color Doppler, but because it can help us to localize the tumor. Now I'm going to talk about the sonographic structured assessment of women with cervical cancer. We need to measure the tumor in 3 dimensions. In women with small tumors, we should measure the distance from the cranial margin of the tumor to the inner cervical os. We should localize the tumor, whether is it only below the vaginal fornices or it's also above. Then we're going to look for deep stromal and parametrial invasion, and we're going to look for other spreads such as bulky lymph nodes and hydronephrosis. Okay, here is the longitudinal section. In the longitudinal section, we measure the anteroposterior diameter of the tumor and the cervical fundal diameter of the tumor. We then go to the transversal plane where we measure the lateral dimensions of the tumor. in women where you consider fertility-sparing surgery using trachelectomy, it is important that to try to assess if there is enough cervix left when you have resected the tumor to be able to make a cerclage. So then you should measure the distance from the cranial margin of the tumor to the inner cervical os. And this can easily be done using 3D ultrasound. I will soon show you this. It's also important to localize the tumor, because if it's only an exophytic tumor growing down here and there is no vaginal spread or paracolpic spread, then even though the tumor is bulky, it will not invade the parametria. Whereas if the tumor is located here, it will more easily invade the parametria with a higher risk of lymph node metastases. So you should look for the uterine arteries, because the uterine arteries is the landmark where the parametria begin. So this is a 3D image. This is a coronal view. Here you can see the arrival of the uterine arteries. This is the most distal slide, almost at the external os. Here is the next slide at the mid-cervical os, and here is the plane of the fornices. And as you can see, here you have the tumor in the distant slide, in the second slide, whereas at the arrival of the uterine arteries, there is no tumor seen. In the transversal section, we will also look for the depth of the stromal invasion. We can also measure the minimal margin from the tumor to the pericervical fascia. And in the longitudinal section, we shall assess the anterior parametria and the posterior parametria. I will show you this in some dynamic clips. Well, Daniela Fischerova, she's written a beautiful paper on how to assess parametrial invasion. This can be graded. If there is only minor invasion, you call that the paracervical fascia is disrupted. If it comes deeper, you say that this is incipient infiltration, we have nodular infiltration, and we also have discontinuous infiltration. This grading can also be done when you're talking of the amount of infiltration towards the bladder or rectum, whether it's only invading the septum or whether it's invading the hypoechoic muscle layer or even the surface of the mucosa within the bladder. So let's go to a clip. Now we are in the longitudinal section. And the white structure you see here, this is the vesicouterine septum. And here in the cervix, we have quite a large tumor. And by going slowly, pushing a bit, you can actually see this small black finger-like extension. Can you see them? Yes. Here you can see them. And this is actually when the vesicouterine septum is disrupted by the tumor. We then proceed to, this is the rectovaginal septum, and we go from one side to the other. And in this case, we cannot, there is some shadowing, but we can see no clear disruption of the fascia here. So this is also in the longitudinal section. We continue it in the longitudinal section, but this time we slide all the way out to the parametria. And if you see carefully, you can see when you do this slow sliding that there are some small finger-like extensions when you do this assessment. Here you can see it's like small finger-like extension. It takes some training before you know what to look for. Now we are in the transversal section. You can also see small black finger-like extensions reaching out into the parametria, disrupting the pericervical fascia. Here you can see parametrial invasion on the frozen images. And color Doppler confirms the location of the tumor. So The take-home message is that ultrasound is at least as good as MRI for the assessment of early cervical cancer. Most cervical tumors are well vascularized. Adenocarcinomas are more often isoechoic, whereas squamous cell cancer are more often hypoechoic. 3D is not essential in the assessment, but it can help you to assess the parametria. And a structure examination technique is valuable. Now you're going to help me with some cases. This is the first case. Can you see the tumor here? Yes? Here is the tumor. Based on only this image, do you feel it's invading the parametria? No? No and yes. We continue. We take a now clip. Now we are in the transversal section. We're sliding down slowly. Can you see any disruption of the pericervical fascia? No? And then we take another image. And you can also see how I am pushing here to see if it's moving. I'm pushing to see if it's sliding. It seems to be sliding freely. And then we look for the color Doppler. So in this case, I would say that this is probably deep. It's invading more than 2/3. The stromal invasion is probably more than 2/3, but it's not invading the parametria according to my assessment. So do you agree on that it's most probably more than 2/3, but I think that there is a small margin around the tumor. Now we will go, we do the transversal section, sliding down slowly, slowly. This is the uterine arteries. We go down, down, down. And here is some kind of slightly irregular area here. Would you agree with me? Yes, good. And then we put on the color Doppler. You can also see that there is some increased vascularization in this area. We turn around. And it was a small tumor. It's only about 1.5 centimeters, this tumor, but it's clearly seen on ultrasound. Okay. This is another case. We are in the transversal section here. We rotate to the longitudinal section. We do it once more, I think. Would you say that, would you be sure, would you say that could be some parametrial invasion here, yes or no? Yes, yes, yes. Well, there's nothing in the posterior parametria here, and there was nothing towards the bladder, but here you can see that it seems to be irregular. You cannot see, there is nothing here and nothing there, but when you go over to the transversal section, we wait once more, you can see that this is clearly irregular here. So, this is another slide. It is irregular here. So this is not rocket science. I am quite confident that ultrasound performs really well when it comes to cervical cancer. In my opinion, it's more difficult actually to assess myometrial invasion in a woman with endometrial cancer than it is to assess the extension of a cervical tumor. So I would like to see a more worldwide spread of ultrasound in cervical cancer, being able to offer this to more women if an MRI is not available, because it is an extremely good technique and it's not that difficult to learn how to do this assessment. Thank you all for your attention.
Before we go on to the applications of contrast in gynecology, let me brief you a little on contrast because some of you may not be still using it. So in India, we have two types of contrast media which have been approved. One is SonoView, which is a sulfur hexafluoride, and the second is Definity, which is perfluorine lipid microspheres. So these are basically lipids, these are basically microbubbles which are encrusted with albumin or lipids so that they are stabilized and we can use it in the body. Now both these define the sense that SonoView we have to prepare with a vial. So we have a solvent and a vial with powder, and we prepare about 5 ml at a time, and Definity is about 2 ml, and we require a special vial mix to prepare Definity. So what happens is once you inject them in the circulation, these microbubbles mix up with the RBCs, and very fortunately when we interrogate them with the ultrasound probe, that is typically 2 megahertz to 20 megahertz, these bubbles resonate, they sort of oscillate, and because of these oscillations they generate harmonic signals, and we pick up these harmonic signals. These microbubbles also burst when an ultrasound wave hits them, and we can take advantage of this bursting to deliver drugs at a particular site in the body, which is again what is going to happen in the future. So the best thing, so how we use them in liver, just for an example, I'll show you 2 slides. We have 4 lesions which almost look hypoechoic on ultrasound. They look similar, but if you inject contrast, we are able to differentiate them. Here, this one is picking up the contrast and washing it out fast, so that's typical of hepatoma. This one is showing a perinodular persistent enhancement, which is typical of an hemangioma. This is showing only a peripheral enhancement, no intrinsic enhancement, that's an unliquefied abscess. And this one is showing an intense enhancement with a scar in the late phase, which is typical of an FNH. So what looks similar on ultrasound can be differentiated with the help of contrast. Similarly, here we have 3 lesions in the liver, all look hyperechoic, all look similar. We inject contrast. This one is washing out the contrast fast. There's one more lesion there, so these are metastatic deposits. This one is showing iso enhancement in all phases, so this is just a focal fat area, and this one is showing again a classical perinodular enhancement, which is typical of an hemangioma. So this is how we use contrast in our practice for liver. And as far as liver is concerned, of course, we have well-defined guidelines. So the best thing about these microbubbles, unlike CT-MR contrast, is that there are no side effects, there are no nephrotoxic effect, and therefore even if a patient has CRF, you can use them. We don't do creatinine level before we inject them. So as far as liver is concerned, we have well-defined guidelines, and I have been very fortunate to be a part of this group of guidelines, and we use these guidelines all over the world. So with this sort of a brief on what contrast media are, let us see how we can use them in gynecology. So in gynec, in fact, if you look at the applications which we have been doing in the last few years, they are really wide. But the basic principle is the same. So when color Doppler came, we thought, wow, we have got something which will tell us blood flow at all levels. And we were excited, and we started using color Doppler at all points. But color Doppler does not show us microvascular blood flow at a microvascular level. It does not show us blood flow at a capillary level, which is what we want to see. And contrast, on the other hand, does that. So typically this is a GTD. We feel, wow, it's quite vascular, but actually contrast is giving us much more information in this patient than color Doppler. So we have been using it in a number of, we have been practically using it in all situations as far as gynec is concerned, but today we'll focus mainly on malignancies, and I'll also talk on how to differentiate fibroids from adenomyosis using contrast. We have been using saline, of course, to look at tubal patency. So now we use contrast to look at the tube. We can see the entire tube and the spill, and we can do 3D reconstruction, and Sonal is probably one of the best persons in the world to show fallopian tube patency with the help of contrast. So Praveen has talked about CA endometrium, and he also pointed out that basically ultrasound as well as color Doppler has limitations in a day-to-day practice. And he also pointed out in his last slide that maybe contrast and elastography will be useful to us. So let's see how they are useful to us, especially contrast. So if you look at the contrast uptake in a normal uterus or a uterus with a thick endometrium, if the endometrium is normal, what we observe is that the myometrium enhances much earlier as compared to the endometrium. The peak enhancement in the myometrium is also much more, and the intensity of enhancement is also much more as compared to the endometrium. And therefore, even if you have a thick endometrium which is benign, cystic endometrial hyperplasia, the same pattern remains. That means the myometrium enhances early, and the myometrium enhances much more as compared to the endometrium. So rather than look at it subjectively, we need something more concrete or objective, and therefore we have these time intensity curves. And therefore, if I put my yellow dot in the myometrium, and if I put my red dot in the endometrium, I realize that the myometrium is enhancing early, and as well as the enhancement within the myometrium is much more as compared to the endometrium. So we can do it subjectively and we can do it objectively. When you have malignancies, on the other hand, what we observe is that the enhancement of the endometrium is much faster, sometimes even before the myometrium or sometimes along with the myometrium. We also observe that the enhancement within the endometrium is much more during the peak and overall as compared to the surrounding myometrium. And therefore, in this patient of CA endometrium, if my red dot is within the myometrium and my yellow dot is in the endometrium, I realize that the endometrium is enhanced earlier, and the intensity of enhancement in the endometrium is much more as compared to the myometrium. So we have a lot of literature which has come up, and this is one of the first papers in 2009 where they said that in tumors the arrival time is very fast, the peak time of course is shorter, and the arrival intensity as well as the peak intensity and overall enhancement is much more in malignancies as compared to benign endometriomes. And this is one more patient where we thought it's a thick cystic endometrium, but there was little blood flow there. So we did a contrast, and we can see that endometrium is enhancing quite early, and the enhancement within the endometrium is early. That's a yellow dot there, and much more as compared to the myometrium. So this is another study which was published, I think, in 2014, but it's a very large series. And what they did is, of course, compared the endometrial flow to in benign versus an endometrial malignancies, and they plotted up this graph of endometrium to endometrium, and they observed that the red curve, which is the time intensity curve for endometrial carcinoma, there's a very rapid rise, there's a rapid decline with a very sharp peak, whereas the blue curve, which is representing benign endometrial lesions, shows a rapid rise, a slow decline with a blunt peak, and they were able to differentiate benign versus malignant with a very high degree of accuracy. So here's another patient. Again, we can see that the endometrium is enhancing very early as soon as we injected contrast, and as compared to the myometrium. If I plot, the endometrium again is enhancing much more as compared to the myometrium, and this is something very, very worrisome. This group also found out that by using contrast, they could judge the depth of invasion of the malignancy within the myometrium, though we haven't done this so far. Now we also know that endometrial malignancies can be focal. So typically, for example, and therefore when you sample, sometimes you can miss on that, and this is where contrast can help. Here, for example, we do see that there's a focal increased blood flow on color Doppler, but on contrast we see that there is marked enhancement in this area of the endometrium as compared to the rest of the endometrium, and therefore we suggested to the gynecologist that either you do a hysteroscopic biopsy or you do a DNS. If you do a sampling, make sure that you sample this area, and this was a very early malignancy in that area. So we can also guide the biopsy with the help of contrast. There are a lot of articles. Again, a common dilemma in endometrial polyps is trying to differentiate benign from endometrial polyps, and there are a lot of articles on that trying to differentiate between the two, though we haven't had much experience with polyps as such. So typically, gestational trophoblastic disease is another area where we can potentially use them. We could use them to judge the extent of myometrial invasion. We could also use the contrast to follow up these patients of gestational trophoblastic disease along with beta-HCG, etc. I'll just briefly mention about fibroid versus adenomyosis, though these are not malignancies. And I think there was a session on fibroid versus adenomyosis earlier. But this is very interesting, and I thought I'll just share with you. Basically, we know that fibroids are well defined. They're typically more hypoechoic, and they have a peripheral sort of a flow around them. They have a dripping vessel which is all around the fibroid. Whereas adenomyosis have entirely different appearance on grayscale. Various things have been described, like a globular enlargement, asymmetrical enlargement, myometrial cyst, hyperechoic islands, of course interrupted endometrial myometrial interface, hyperechoic subendometrial lines, etc., etc. These again have limitations, and very often we have difficulty in differentiating focal adenomyosis from fibroids. So that's a typical adenomyosis with myometrial cysts and scattered vessels. The vessels within adenomyosis on color Doppler are scattered and quite irregular. So if you inject contrast, we realize that in fibroids what we see is a centripetal enhancement. So we see the capsule enhancing first, and with time we see a gradual enhancement coming from the periphery into the center. That is very typical of a fibroid. Whereas in adenomyosis, what we see is penetrating vessels which come from within the tumor. They are randomly scattered and heterogeneous, and they do not follow any pattern, unlike a fibroid. And that is not very surprising. If you look at a cut section of a fibroid and compare it with the adenomyosis, fibroids have peripheral vessels with central going to the center, whereas adenomyosis has scattered vessels all over. The other thing is that fibroids take time to fill up. So typically we see enhancement in the periphery coming up, and then we see a gradual enhancement coming from the periphery to the center. And the time it takes also is much more as compared to adenomyosis. In adenomyosis, they fill up very fast, and as we said, the vessels are random, they are scattered, they come from within the tumor, and this is very often referred to as a moth-eaten filling defect within the adenomatic uterus with contrast. So that's another typical example of focal adenomyosis on the posterior wall. So basically this basket pattern is typical of fibroid. We might see a feeder vessel, whereas this moth-eaten appearance is very typical of adenomyosis. And this was again a very large study done, I think almost 10 years back. But the same thing is true. This basket pattern is diagnostic of fibroids. And number two is the early filling. Early filling is very often seen in adenomyosis as compared to fibroids which fill up late. We have also been using elastography to differentiate fibroids from adenomyosis. Typically fibroids show dark blue color because they are much harder as compared to adenomyosis, and we have a variety of colors in adenomyosis, whereas here we have uniformity of colors in fibroids as compared to adenomyosis. The other use of contrast is when you have atypical fibroids. Suppose you have an adnexal mass which looks like a broad ligament fibroid, but you are also worried about an ovarian mass. If this mass shows a typical fibroid-like pattern with a peripheral enhancement and a centripetal filling, you can be more sure that you are dealing with a fibroid rather than an ovarian mass. Or for that matter, if you have a cervical mass and that shows a typical pattern of a fibroid, again you can be very sure that this is a fibroid and it doesn't look like a malignancy. Then of course we have been using contrast in fibroids after HIFU. In our center we were the first to start HIFU in the country. So we have been using contrast after HIFU to see whether there has been adequate devascularization or no, and of course after embolization. With this background, we now of course move on to ovarian masses. Now whenever we have a classical ovarian mass like this, you are all familiar with pattern recognition, and all of you will say this is malignancy, of course. So we have a solid mass, vascular, high diastolic flow, etc. Therefore you don't require contrast in such a situation. But if I were to inject contrast, what I would get is marked enhancement of the entire tumor, especially the solid areas, marked enhancement of the septae, which would be typically seen in a malignancy. At this point of time, we don't know whether contrast will help us in diagnosing ovarian tumors, ovarian malignancy. Moreover, whether it will help us in diagnosing early ovarian malignancy, though the evidence is quite good. But what I can say is that contrast helps us in ruling out malignancy in a large majority of patients. For example, these are two complex masses where we have solid and cystic areas on grayscale or on color Doppler. We may not be very sure, but on contrast I know that there is not a single speck of contrast going there, and these are definitely hemorrhagic cysts. Similarly, here we have two masses. If you just blind yourself and don't see these two slides and see A and B, they almost look similar. But if you look at the contrast pattern, this is markedly enhancing all over, along the periphery, in the solid areas, along the septae, whereas here there is not a single bubble going inside. I can be 100% sure that this is benign and maybe a hemorrhagic cyst and ask for a follow-up, whereas here I will be aggressive. So contrast definitely helps in ruling out malignancy in a larger chunk of patients in a day-to-day practice. Similarly, here we had a solid-looking tumor which we were worried about, but it was not showing any enhancement, and this was a benign ovarian mass. And then of course, if you have septae which are thick and septae which are markedly enhancing, one would be worried about. Similarly, if you have papillary projections which are large, typically 7-9 millimeters, and if these are enhancing on contrast, one would be worried about. And we have 2 or 3 cases where we had multiple papillary projections markedly enhancing on contrast. This was a malignancy. We had one more patient where we had small papillary projections, but they showed a lot of enhancement on contrast. This was again a borderline tumor which was operated upon at a hospital. So typically, just like endometrium or anywhere else in the body, we can be subjective or we can be objective. That means we can plot the time intensity curves even in the ovarian mass. And what has been observed is that there is a statistical difference between malignancies as far as the peak enhancement is concerned. That means the peak enhancement comes within malignant masses much earlier as compared to normal ovarian tissue or benign masses. But what is also observed, unlike other tumors, is that the half washout time is much more, or the area under the curve is much more. What I mean thereby is that the contrast remains within the ovarian malignancies for a longer time as compared to benign tumors or as compared to a normal ovary. And I think Arthur was one of the first authors to come up with this, and he shared this with me even before this was published. And what they realized is that the time intensity, on the time intensity curve, the time to bolus injection, that means the tumor picks up the contrast fast, but the contrast remains within the tumor for a longer time. That means the area under the curve, if the area under the curve is larger, that means the contrast is retained within the tumor for quite some time. So here we had a patient who was postmenopausal. We felt the ovary quite bulky for her age. We did an elastography which was quite hard, and we did a contrast, and it was markedly enhancing. And this we warned the clinician, and this was a very early ovarian malignancy we picked up. And that's the time intensity curve. If you look at the time intensity curve within the mass, we see a marked enhancement and sustained contrast within the lesion as compared to the surrounding ovary or as compared to normal tissue. Another example where again we picked up an early ovarian cancer. There was again a solid looking area within the ovary. We have been trying elastography. We don't know how useful it is going to be. Again, marked enhancement. And if you look at the pattern, again intense peak enhancement and sustained contrast within the lesion. And this was another one more lesion. And we have done one more this week. I want to know the follow-up. Let's see what happens. So this was a study done in 2015, published this year, where they said that the sensitivity and specificity of ultrasound contrast in diagnosing ovarian cancer was 96 and 91%, which are very encouraging figures. This is another study which is actually based, which is a sort of a meta-analysis done on various studies right from 2003 to 2014 or 13, and they found out that the overall incidence of false positive and false negative is very low. So definitely it is a quite a promising technique. And this is one more patient where we picked up an early ovarian cancer, again in a postmenopausal patient, routine health checkup, bulky ovary, very vascular, intensely enhancing. Again, we warned the clinician, and this was picked up. But of course, these are just random cases, and we cannot come to any conclusion based on this. Other thing which happens very often in India is we have tuberculosis which mimics malignancies. So typically we have ascites, and we have these deposits on the peritoneal surface or along the omentum, which could be tuberculous or which could be malignant. So if you inject contrast, and if all these peritoneal deposits are enhancing, we can be sure that we are dealing with a malignancy and not tuberculosis. Similarly, after surgery, very often we see masses which come up, and sometimes the PET scan shows that there is a lesion. We are not seeing it on ultrasound or not sure about what it is. Even when we have such a mass, and if that shows enhancement on contrast, we can make a confident diagnosis of recurrence. But there are going to be overlaps. For example, an inflammatory tumors would also show enhancement. But then, of course, we have to go into the history. We have to go into the rest of the things like B mode findings, etc., pattern recognition to differentiate between them. We can also do a 3D reconstruction. That means as the contrast comes within the tumor, we can do a 3D reconstruction. And we always use this technique in the liver to characterize the masses. And similarly, we could use it in ovarian tumors. These are two examples of a dysgeominoma where we did a 3D reconstruction. Cervical malignancy, we don't have much experience, but I believe Elizabeth talked about it yesterday. But typically what is interesting here is two things. One is, if the mass is something like a fibroid, then that will show a typical pattern of a fibroid coming from the periphery to the center. And we have seen that typically, as she showed one or two cases where there is subtle changes in the cervical architecture, and there was increased blood flow. If you inject contrast, this difference stands out much more, this area enhances much more as compared to the rest of the cervix. And again, we have done random cases, though we don't have figures as such, where we have picked up early cervical malignancies with the help of contrast. Just to finish off, in a way, we are using contrast to diagnose torsion, and we have almost about 25 cases with us. We know that on grayscale, we have the pedicle sign or the whirlpool sign, which is seen on grayscale as well as color. But on contrast, we can see this sign much, much better, and we can give a more confident diagnosis of torsion, because you can see that there is a complete hypoperfusion in this ovary as compared to a normal looking ovary. Furthermore, now we are trying to find out whether with contrast we will be able to tell the clinician how much of the ovary is viable or there is no viable tissue. And here, for example, there is no bubble going in this lesion at all, and one would expect it to be gangrenous, as we can see on the scopy. So overall, it's a very promising field, and I think after more and more people start using it, we will be able to exploit it. Like Sonal, I said, she does one of the best HSGs on contrast, and I think once everyone starts using it, we can exploit this wonderful modality to full. Thank you so much.
Where the, I mean, other than the history and the,
Yeah, I think inflammatory tumor masses we diagnose by characterization on our pattern recognition most and history. So usually I don't think there's a dilemma between inflammatory tumor masses much versus ovarian cancer. So this...
But with contrast.
I mean, contrast, if there's a lot of inflammation, one would expect increased vascularity. But I think the diagnosis would be made typically on our grayscale and history, and maybe a good number of them we may not be using contrast.
I think we have to take contrast as complementary. In a sense, we don't think we can purely depend on that.
Absolutely.
We take the pattern recognition, we take the easy descriptors, we take iota rules plus contrast. It becomes much more
especially
comprehensive.
for tuberculosis and overlaps.
Yeah.
This is just a comment on Dr. Praveen's presentation. See, I think, the cutoff we keep as 4 millimeters for all postmenopausal women. Now we have realized that there are two different kinds of postmenopausal women. One, those present with postmenopausal bleeding, and the other ones which are not asymptomatic and just had a higher thickness of endometrium. So they are totally different. So I think, your other parameters will come into, will be very useful to us, because we do many more unnecessary hysteroscopies, DNCs on women to find one case in asymptomatic postmenopausal women if we keep the cutoff as 4 or 5. So now they say the same sensitivity and specificity we reach by increasing the cutoff to 11 millimeters in postmenopausal women without any symptoms.
Well, I can make a comment on that actually in asymptomatic women there's not been shown to be any exact cutoff that is really good. So I think if there is a high suspicion with the family history of obese women, you should look at the morphology, because it's not been shown that screening for an endometrial cancer is effective. So it's quite questionable whether you should look on asymptomatic women. But if it clearly looks suspicious with malignant features, then I think you should take a biopsy. And this has more to do with the sonographic features than to do with the thickness, because we know the thickness is only good in women with symptoms.
I would request Dr. Elizabeth to, scanning the cervix requires a little bit more of technique than it does scanning the rest of the uterine body. And I think we will all benefit if you tell us what would be your special ways of scanning. I mean, I've read a few and I'm using some stuff, but I'd like to hear from you, please.
Well, I think the first tips is actually to start to scan the cervix in every patient, because we did the reproducibility on scanning women with endometrial cancer, and we found that experts were better than any gynecologist when it came to assessing the cervix. But when it came to assessing myometrial invasion, any gynecologist could do this. So I think the primary step is to start scanning the cervix. And when it comes to cervical cancer, I also think you should not push too hard and go too vigorously in, because some of the smaller cancer, they will be very superficial. And if you push too hard, you will not be able to see them. So in my opinion, it's a little bit the same as when you scan for endometriosis. You start in the introitus. You also want to take a look at the vaginal walls. So first I go very, very slowly in, looking at the vesico-uterine septum, slowly moving from one side to the other. Then I retract again, I go back, and I look towards the rectovaginal septum. And then I go from one side to the other side to look at the parametria and to look also to the sacrouterine ligaments, because this is also a common place for infiltration. And then I turn to the other transversal section, going very, very slowly from the rectum all the way atop through the whole uterus and see the bladder. So you should make these slow sweeps, and then you should also try to push. Because if there is impingement in the parametria, you will find that this area is more rigid. It will not slide in the same way as if there is no invasion. So you should go slowly and push.
This is something I've been doing. I don't know if it, you think what, I'd like to know what you think. In some cases, I have been instilling the gel into the vagina for better visualization of the surface of the cervix, particularly for small early cervical lesions. And then you put on your color Doppler. So we put in the gel, take out all the air, we just put in the gel. And with the probe cover, what happens is, if moment you touch the gel, just moves away. So now I take a 10 ml syringe, I empty out the air, I put in and slowly enter, and I think the cervix is beautifully seen.
I think this can be a good, very good comment to try. And I think if you have difficulties, you can also try transrectally if it's a big tumor, because then you get another angle. So I think this is a very good tip. And another tip, if you have difficulties, then you can also go transrectally, especially if it's a big bulky tumor with heavy bleeding. It might actually be an advantage to go through the transrectal route.
Thank you. And I have one, thing about contrast. Because maybe we are not using it yet, it is to me very similar to what a good Doppler flow study is, other than the flow parameters, those. And I'm sure it has some advantages. But I feel personally what I find very challenging is to see as early endometrial carcinoma in a mid-position uterus. And I think that is where contrast will help us more than anywhere else, because it is impossible to see a close-up. I mean, on transabdominal, you can see the endometrium, but on transvaginal scan, if you want to do a study and it's a mid-position uterus, I think contrast will help a lot in picking up early malignancies.
But I think the problem is, it's when the endometrial cancer is small, it will look like a hyperplasia. We found in one of my old studies that if you have an endometrial cancer with a thickness of less than 15 millimeters, it was extremely difficult to tell whether it was a cancer or whether it was only hyperplasia. But once the cancer gets bulky, it's not rocket science, then it's easy. But the small early cancers, they can be quite difficult because they look like hyperplasia. They are hyperechoic, they have a regular endometrial myometrial border. So it's not until they get big that you actually feel quite confident.
Contrast is going to help us.
Yeah. We hope for that.
Any more questions? Yeah.
My question to Dr. Parveen. Like we see routine cases, follow-up cases of CA breast, the patients who are on tamoxifen. And one of the patients, we got endometrial thickness as 10 millimeter, but it was not homogeneous. Like if we study the morphology, it was showing just thin septa in it. So because she was a very VIP case, herself a doctor,
So she went in for biopsy, but nothing came out. Maybe some clots or something. Can we comment on the morphology of the endometrium in such case?
The most important thing is that you can't just depend only on thickness, only on morphology, and only on the endomyometrial interface. See, it's a combination of all these things. That is the reason why the terms have been defined, and each one has its own importance. Suppose, for example, in such situation where there was a tamoxifen, history of tamoxifen, and the endometrium is thick, and naturally with your clinical background, you know that there is the possibility of endometrial hyperplasia. In that situation, where we have a strong suspicion of an endometrial lesion or an endometrial malignancy, I think saline infusion sonography will be definitely helpful to us before doing invasive endometrial biopsy.
Okay. And so what is the risk of spill of cancer in saline infusion sonography?
Theoretically, yes, but practically, no.
Okay. Thank you.
Any more questions? I believe we can end the session here, and thank you all to all the speakers. It was an excellent session. And thanks to the audience also.